Shiva, it's still the same.
Still bad.
Samuel sir, can you hear us?
He's still unmuted, sir.
No, I have not muted. It's unmuted only.
Yes, Shiva, now you are very clear.
Oh, okay, right. Thank you.
Very, very clear.
Yeah, fine.
Now Matthew Samuel sir has joined, but he's still in the mute mode. We need to see him and then probably we'll start off. Yes, sir. Sir, we can see you. Sir, can you hear us?
Yeah, I can hear you.
Yeah.
Good evening, sir.
Good evening, sir.
Good evening.
Good evening, sir. Shiva. Nice to meet you.
Hi, everybody. Shiva. I think they have put the name for Shiva. Some Laju or somebody.
Sir, your voice is echoing a little bit.
You're using microphone or you're using the computer audio
No.
with the thing?
Only computer audio.
Okay.
Sir, it's better now as you come closer to the computer.
Okay, I'll sit as close as possible.
Yes, sir. Shall we start? Sir, can we go ahead? It's 6 o'clock now.
1 minute, I'll just.
Hi.
Good evening.
Good
Hey,
evening.
Girish. Hi, Girish.
Sorry, I was stuck in the hospital today.
Okay.
Long day with another relative is in COVID status. So, Namaste, Samuel sir. How are you?
Yes,
Hey, hi. Hi, Girish. Can you hear me?
Very well, clear and well, sir.
I mean, keeping too busy during the COVID days is something very gratifying, no?
Doing some COVID work, sir.
All of us are out of work.
No, I think it's God's blessing for all cardiologists to look after yourself and family for 3 months.
Absolutely, yeah. You're right, Girish.
True, very
It's
true.
heaven in hell.
Yeah, very true. I think a lot of introspection. Sir should know better. So I think better perspective will emerge after COVID, I guess.
I hope so.
Yeah.
Deepak, shall we start?
Yes, sir. Yes, sir. Sir, shall we go ahead? Sir, small introduction, sir. Good evening to all of you. It's my pleasant privilege to invite you all and welcome you all to this particular webinar on basics of coronary angioplasty and how to avoid, prevent complications and manage complications. Now, when we started doing our DM cardiology in 2000, we never used to attend conferences, but the first one that I attended was the Indo-French conference that was conducted in Chennai, and Dr. Matthew Samuel sir and Mary Claude Morris were the lead operators during the live course, and I was so excited by sir's talk, the presentations, the words of wisdom. Even now, 20 years down the line, every time I get a chance to listen to him, I never miss that. Sir, we learned a lot of basics from you in cardiology and the most complex stuff from you. And so I thought it will be a good opportunity for the youngsters also to listen to you. So we never had to think about any other person to moderate this session. So thank you so much for taking your time off this weekend and being with us. Let me also welcome and thank Dr. Vijay Kumar. Vijay Kumar is the senior consultant cardiologist at Madras Medical Mission. He is supposed to be the best person with regards to physiology and imaging in India. Maybe not in India, in our continent. He's supposed to be the best person. Any doubt, you can phone him up anytime, talk to him. Vijay, thank you for your time. Let me also welcome Dr. Shiva, the most aggressive interventional cardiologist in Tamil Nadu. Shiva and his team, Dr. Sampath and Dr. Selmani and team. Shiva, thank you. Thank you so much for being with us. Let me also invite Dr. Girish. Let me also thank you for being with us, Dr. Girish. He's the chief cardiologist at Apollo Hospitals in Bangalore. Thank you for being with us. I hope this session turns out to be very useful for at least the youngsters, with somebody like Matthew Samuel sir being with us. And with this introduction, let me request Matthew Samuel sir to take over the session and go ahead with it. Sir, kindly go ahead.
Thank you, Deepak. Thank you all, and to all the youngsters who are waiting to listen to very, very important sessions today. I should thank Deepak to have selected this, because people have started forgetting, don't want to know how to select a guiding catheter or a guide wire, but they want to do the left main angioplasty. That is the trend today. Deviating from that, coming back to the basics, it's something encouraging and very worthwhile exercise what you are doing. And they have selected me to moderate the session because over the years you must have seen I'm the person who has had the maximum complications. So naturally they have to select that person to be the moderator. And what we have done over the years is openly discuss all the complications. Genuinely, I wanted to extend my foot for all of you to stand and grow from there. Learn from the mistakes. You don't have to commit the same mistake what I did. I could get away with those mistakes because there is nobody else who could have corrected me. But today you have the opportunity to learn from our mistakes. Let us see what you will gain from today's 2 hours of intensive, detailed discussions on different topics. And excellent speakers. You have got Vijay Kumar and ending off with Deepak. Shall we start with Vijay? Vijay, please go ahead. He will talk on the femoral side.
Thank you so much, sir. Share my slide. So, good evening to everyone. I thank Dr. Deepak and Matthew sir for this opportunity. And there is a small conflict maybe among the people sitting here. I might have done the least number of femoral punches. And I'm not sure I'm the appropriate person to deliver this talk, but I'll just try to do whatever best I can do. So we start with, we all know, so we all use radial access. That has become the default strategy for coronary angiography and PCI. And studies have shown that it is associated with a lower incidence of access site complications, and the outcomes are obviously better because of this low access site and bleeding complications. And however, with the complex coronary interventions, need for hemodynamic support, and most of the structural heart endovascular interventions still mandate femoral approach. And femoral access site complications are common and may sometimes be life-threatening. And optimal access and post-procedural management is essential to avoid these complications. First, we shall start with some of the basic anatomy. And we all know the infrarenal abdominal aorta that divide into 2 common iliac arteries. This common iliac artery, they run down into pelvis. They divide into an external iliac and an internal iliac. And the internal iliac goes down into the pelvis to supply the pelvic organs. External iliac artery runs over the pelvic organs and the muscle tissue without a bone support towards the thigh. So below the inguinal ligament, which is connecting from anterior iliac spine to the pubic tubercle, it just goes across and becomes the common femoral artery. So this whole part is without a bone support. And when it becomes common femoral artery, that's where it comes over the bone again. So it just goes down and goes down over the pubic bone and the femoral head, and then divides into its branches, the deep femoral and superficial femoral. Again, if you do deep and superficial femoral arteries, again, much away from bone, it is only lying on the muscle mass. So only this part of the artery, that is a common femoral artery, which goes over the pubic bone and your femoral head, is the only part that has a bony support throughout. This goes from external iliac artery to branches of the common femoral artery. So this is where we have to puncture, because most of these femoral access sites are manually compressed. So you have to aim for a bone for support for your compression like this. So this is the only part of the artery which is over the bone, so that is where you have to puncture. And there are two important branches you have to remember. One is the inferior epigastric artery. Inferior epigastric artery is actually a branch of external iliac artery, which goes down behind the inguinal ligament and goes around the inguinal ligament and goes to the anterior abdominal wall. So the lower margin of this inferior epigastric artery marks your retroperineal space and your inguinal ligament. Another branch is complex iliac artery. This is not important to mark. It just goes along your inguinal ligament. And one important caveat for this branch is when you use a micropuncture access, the wire often goes into this branch. So rarely it can go and perforate and produce hematomas here. So this is the basics of your anatomy of your femoral artery. The most important thing is the landmark here, which is the pubic bone and femoral head, and the common femoral artery, which is overlaying it. That is the only part which is compressible, which lies over the bone. So any puncture above this landmark can result in not compressible and result in retroperineal hematoma. And any puncture below this, that may result, again, you are not able to compress, that may result in pseudoaneurysms and hematomas and so moving forward. So what are the contraindications for femoral puncture? It is not all absolute contraindications. Few of them are absolute and few of them relative, or you have to take more care when you do femoral access. One is the most important thing is peripheral vascular, particularly the occlusive disease, and the prior femoral artery bypass graft surgery, and presence of extensive inguinal scarring from radiation therapy, surgery, and prior catheterization. Again, this is not an absolute contraindication. The presence of excessively tortuous and calcified iliac arteries, particularly when you have to use a large bore access, and a morbid obesity. And these things you have to remember, even though these are not contraindications, again, more prone for femoral site complications. CRF on hemodialysis, and other conditions associated with wide pulse pressure, such as systemic hypertension in elderly, aortic regurgitation, and similar conditions. Whenever you have a wide pulse pressure, again, they're more prone to developing bleeding complications. CRF is a very, very important subset. So where it is a high pulse pressure, particularly patients who are on hemodialysis, along with the platelet and bleeding coagulation factor abnormalities predisposed them to bleeding complications. And starting with the femoral access kit, this is the kit we used to use when we were students and in early part of our practice here. So this is a 018 gauge needle, and this is a wire we use it. This is 035 wire, and this is the one which almost we replace this bigger needles with this micropuncture. This is the one we commonly use for all our femoral access. And this is your 21 gauge introducer needle, and this is coming in two sizes. One is a 5 French access or 4 French access sheets, and this is the 018 wire. So this is the system we commonly use now. And see the dramatic difference here. The bigger needle produces a hole of 1.3 millimeter square, So you have to, if suppose your puncture is not in the optimal position, you have to compress for a bit longer time. And this one produces only a 0.5 millimeter area hole in the femoral artery. So you apply for pressure for 2-3 minutes, you should be all right. And this is a handheld ultrasound system, the V-scan from GE. This is the one we commonly use for using alpha-guided puncture. And what are the various methods for femoral access? First one is a palpatory method. This is the one we used to use when we were students. And the second one is the fluoroscopic. And the third one is ultrasound-guided method. And fourth one is the combined method. Let's start with the palpatory method. This is a method we were taught when we were students in JIPMA. So, and how do you do this one? You determine the location of the inguinal ligament. Commonly, we use inguinal crease, or you just palpate and use the iliac spine, your pubic tubercle, and keep your fingers over that. So there's a middle finger which marks your inguinal ligament, and you select a point 3 millimeters, 3 centimeters below this. So then you start your puncture, and your puncture needle arterial axis end up around 2 millimeters below the ligament. That is where the middle of the femoral head. So this is how we used to puncture. But what are the problems with this approach? The inguinal crease is not. It is notoriously unreliable in making the location of the inguinal ligament. And it is difficult to appreciate the location of the inguinal ligament with palpation, especially in obese patients. There is a risk of suboptimal access due to variable trajectory of the needle. And there is an inability to control anatomical variants and pathologies such as high bifurcation, plaque, or calcification. Then came the second, though this is an example here. It's just I'm locating the inguinal crease with my forceps here. You just see that how below it is below the femoral head. And suppose I choose this landmark, I end up with a puncture below your femoral head. The second patient, it is exactly on the. This is the most appropriate once your femoral crease is exactly at the lower part of your femoral head. So I start the puncture here, you may end up with a common site. So it is a very unreliable landmark is your femoral crease for in your inguinal ligament. And then came this fluoroscopic axis. There are multiple ways of doing it. One, either you can just keep it, your forceps at the lower part of your femoral head and mark this one with your finger and start your puncture here. And you end up with 1 centimeter above, so you end up with the middle third of your femoral head. Or you can just keep your marker at the middle of the femoral head, keep your finger, and start your puncture 1 centimeter below your finger. Then you end up with the appropriate size in the femoral artery. However, what is the problem with this fluoroscopic guided access? It cannot account for high common femoral artery bifurcation, which is superior to the inferior border of the femoral head and the inferior border of the midpoint of the femoral head, are very high bifurcations, that means superior to the midpoint of the femoral head. So this high bifurcation, this is very high bifurcation. In a study of 940 patients, so the bifurcation occurred in 64% of the patients. It is below the head of the femur, and 98% it is below the mid part of the femoral head. So if you puncture in the middle part, middle third, or at the midpoint, then you most of the time you end up with the common femoral. And another important caveat using this approach. So suppose you see this patient, this is a thin patient with not much of a subcutaneous tissue, and this is your common femoral artery. You start with the lower end of the femoral head, and you aim with a 45-degree angle to the femoral artery. You end up with the site which is below your middle of the femoral head. Suppose you have an obese patient with a lot of subcutaneous tissue, again 45-degree, you end up with an axis which is below the middle of the femoral. This is an important problem you have to understand. Whenever you have to move deeper into the femoral, deeper into the means groin without getting your artery, then you have to be always vigilant. Just screen and see that where you're exactly going, and just pull back, make your trajectory a bit more vertical to avoid high punctures. And the next came this ultrasound guided puncture. Ultrasound guided puncture use ultrasound to select your anterior wall of the femoral artery, and it is above over the femoral head. Okay, that is how we use ultrasound. So what are the problems with this ultrasound guided approach? Finding the femoral bifurcation by ultrasound, we use this method, then scanning up further to hit the Harmon femoral artery. However, fixing on a stick or the Harmon femoral artery, no regard for the location vessel related to the pubis or your femoral head. So the bifurcation, you just select your bifurcation and go up hit your common femoral artery. But this may still be lower than your femoral head, or it is sometimes can be much higher part of the femoral head. So you don't have control over that. Then again, you have to, if you are aiming for an artery, you may go through multiple in and out movements. The access needle may take a zigzag and a jet line track. So that again, it may not be appropriate for your access closure, or it may result in treatment complications. So these are the various drawbacks of your ultrasound guided approach alone. So now what is the recommendation for optimal femoral access? Optimal femoral access is guided by ultrasound fluoroscopy. So ultrasound gets you into the vessel, which achieves a single puncture in the center of the artery and avoids inadvertent injury to the unwanted structures. And use fluoroscopy, which gets you to the vessel in the right place, assures entry into the artery over your pubic bone or your femoral head. The ideal access is a single front wall puncture in the center of the artery at 45-degree angle. So it should be over the pubic bone or femoral head. So this is a way they recommend you to do it. So this you just see that this is ultrasound access, and this is your common femoral. This is your common femoral artery, and this is your femoral vein. And just see that if you just move little below, you see your profunda femoris and superficial femoral artery. This is the point you have to identify. You can just see that we are just locating your artery here, this superficial femoral artery, and this is your deep femoral artery, and this is your venous structure. How do you differentiate these two? Venous structure is usually medial. When you apply compression, the venous structure collapses, the artery doesn't collapse. And here you can just see that you look, just move up, get that artery here, and you can see that. So this is how you locate, use an ultrasound probe, locate to the middle of the femoral head, and use your needle to puncture. You can just see that. You can see the needle movement. The needles are now coming with material that helps you in recognizing yourself when you move inside the tissue plane. Just see that it's exactly landing in the middle of the middle of your femoral artery. And an additional advantage is you just see that the site doesn't have any plaque. You can identify any calcification or a plaque at the site of entry. Once you're done this thing, then I'm just introducing the wire inside. So this is a way they recommend you to do your femoral puncture. And suppose you have to use a large bore access. If again, you can use this fluoroscopy and ultrasound guided method. What are the other methods have been described? This is the method we use commonly for our TAVI access. You can just see that you just put the pigtail into the groin from the opposite side and locate your common femoral artery and puncture through this eye of your pigtail. So that is how you end up exactly on the anterior wall and the middle of the artery. The second method is use a wire as your landmark and use this landmark and puncture this side of the artery. The third thing is you just take an injection that use that road map and you puncture. So these are the various fluoroscopic guided ways of getting access for large bore vessels. Okay, so what are the various tips and tricks? I'm sure Matthew sir will extend more on these things. So these are the few things to remember. If your wire is curling at the tip, you are putting the wire inside, it is curling at the tip. That means that you are not inside the artery. And most often the needle has moved out when you are just trying to take your wire and it has just moved out. And if you need to apply, suppose when the patient is obese, you have to apply a lot of compression with your fingers before entering your artery. You have to make sure that you hold the compression till you put your wire inside. Suppose you just leave your finger, it just releases the tension over your tissues, and that automatically pulls your needle out of the vessel. So that you have to remember, whenever you use a lot of compression, just maintain the compression before you put your wire. And always move a bit. And when you just observe that there is a spurt of blood, always move a little inside. So otherwise, you'll be just end up with the surface of the artery. I'm going to show some of the examples for this. And always aim for an anterior puncture, because inadvertent posterior wall puncture may end up with developing pseudoaneurysms. And always pass the wire under fluoroscopy and try to avoid common circumflex iliac artery, which is the common occurrence when you use your micropuncture wire. And avoid using hydrophilic wire when you are using a bigger needle and puncturing. Try to avoid using hydrophilic wire. And if you're using it, you should never attempt to pull the hydrophilic wire from the needle at the end and shivering the wire. And use an adequate pre-dilatation with the dilators whenever you're having difficulty in entering inside. So particularly in the case with previous access and severe fibrosis. And avoid vertical entry that may result in sheath kinking. And use longer sheath and exchange wires in case of severe tortuosity. And beware of people with thin and wide pulse pressure. They're more prone to develop respiratory complications. And do not administer heparin till you confirm the optimal access position by an hand injection. And take utmost care when you access artery or vein in the presence of adjacencies. Sometimes just goes in a slanting way. So you just so if the artery is going like this, you try to puncture your vein, you may end up with your sheath. So that will end up in a lot of bleeding and hematoma. And always flush the sheath in between exchanges, particularly when you're not administered heparin. Otherwise, the thrombus can form your sheath. And always use long wires. It is our practice always to use. We never use short wires for fitting our sheaths. We always use the long wire and put our sheath. And we never remove the wires at all. We directly take the catheters inside. Do not remove this wire before introducing your catheter. In case the vessel is tortuous, the sheath may be against the vessel wall, and that may create a dissection when you pass your wire. I'm going to show you an example for that. And always check the access before administering heparin. This is very, very important. If there is a low or high puncture is identified, there should be a low threshold to remove the needle. And particularly in a micropuncture needle, it doesn't matter. You just apply manual pressure for 2 to 3 minutes and repuncture again in the correct position. And all long sheaths preferably should be introduced over a support wire to avoid complications, particularly in a tortuous artery. So this is what happens. So this is actually a correctly punctured one. We got a flow of blood. This is what happened actually. So we have to administer a lot of pressure to just get the tissue down. And inadvertently that was released, the needle has come. So that's why you can just see that when you see this type of wire curling, that means you are not inside. This is what it happens. You have to go inside and maintain that position. Then only the wire goes nicely. We just keep it still, you get the blood flow, but the wire will not enter. You just move above the artery on the surface. So this you should avoid. And the second thing, this I was mentioning, this is your circumflex iliac artery. Most of this micropuncture wires, just through this, sometimes it can go to the end and perforate and release hematoma. So it is always a good practice to introduce a wire under fluoroscopy, particularly when you use the micropuncture system. And this is an example of a femoral access with the tortuosity. Whenever you find these type of arteries, this is again micropuncture system. And you always use a stiffer wire, means 435 wire. The fluoroscopy, just gently take this wire around, and I'll never take this wire out. So if there is a severe tortuosity, I just put the sheath in and take a JR4 and just make it. Then each exchange, either you have to use a exchange wire or you have to keep the 035 regular length wire up before removing it. And you just see that the same patient here after removing. So this is what has happened by the wire. You can just see that. Looks like a lot of stenosis here. It's actually the pseudostenosis produced by this tortuous. Just pull out this wire. So this type of vessels, if you're not very careful, you end up dissecting these places. When you just try to push across the place, you end up dissecting these places. Okay. Then again, this is the tortuous artery. Just see that the artery is tortuous here. Your sheath is exactly landing this. If you remove the wire and try to access this, this is where you just end up dissecting. So this should be avoided, and always keep the wire inside before putting your catheter in. So we just always use a long. So you can just see that this is actually the sheath has produced a dissection here. You inadvertently push your wire, then again it ends up with the extensive retrograde dissection. And suppose you find early bifurcation, it is very high up here. So what you have to do, you should not aim for a common femoral artery. You have to select, use the probe again, just keep it here in the middle of the femoral head to try to identify larger of these two vessels, which usually it is superficial femoral artery. They try to access it and just proceed with as if like you are inside the femoral artery. Don't ever try to attempt puncturing here. That will end up in a space where there is no place for your compression to happen. Okay, so now we shall move to some of the exercise complications here. This one of the patient, it is nicely accessed vessel, and so we had some difficulty in pushing. This happens when you use the non-hydrophilic sheet. Now, most of the cases we just switch to thermo sheets which are hydrophilic. Non-hydrophilic sheets, if there is some resistance, it just bevels, and this was just beveled sheet was just tried to push in. That resulted in bleeding here. Because it is a 6 French and it is located over the femoral head, we just could get away with the manual compression for this patient. And this is one of the disastrous patients. And this lady, this is a 42-year-old male and diabetic. He had a stent in 2013 and presented to us with anterior wall MI after discontinuation of his dual antiplatelet therapy. So this was with stent, it was occluded. And because the patient had ongoing chest pain, the decision was made to open the artery. So actually what happened, these type of patients, we just sit them out and talk to the attendant and then again take them back inside the catheterization laboratory. So this was taken in and so they tried putting a sheet was they tried putting wire. So before that heparin was given through intravenous tube. They tried putting a Teflon wire inside that was not going. They tried putting a thermo wire that could not pass. Then they aspirated it. There was no flow. Maybe I think we should not have injected in this place, and that injection was made. You can just see that sheet is totally outside, and it has created a big hematoma, and the blood is seeping into the space. And this up till this point, patient was stable, and within a minute, he's developed groin pain. Initially, hemodynamics were stable, and subsequently started developing abdominal pain. So we quickly took the opposite axis. First thing we did is we reversed heparin and took the pigtail from the opposite side. And this is what we could see. You can just see that our catheter is this thing is totally outside. So it is entered into the femoral artery, and it moved out of the femoral artery. You can just see that femoral artery and come back here. So then we exchange it for a long sheet and crossed with the wire. And we just arranged for cover since we didn't have many of these cover stems in the thing. We just ordered for some from other hospitals. And during the waiting time, you see here, it's totally outside. And we put the wire and serially prolonged the balloon occlusion here. You can just see that how rapidly the hematoma is expanding. It's almost this bladder is fused. This is one of the most sensitive signs of expanding retroperitoneal hematoma. So after prolonged balloon occlusion, the bleeding slowly settled, and with multiple transfusions and volume replacement, and patients' general condition is improved. So we didn't do the PCA, we just left him alone. And you see that still there is some flow in this thing, but overall the hemodynamics others remain stable. So we have already reversed that ring. So we just observe the patients. So what was the most probable thing happened? Then retrospectively, nobody could understand what exactly has happened. So this is what has happened actually. When the patient came out, we just forgot to suture this one. So the sheet actually almost totally came out. And our sister was worried that she is going to get scolded by the consultant. So we just pushed the sheet inside. So without telling anyone, so that is the sheet gone outside the femoral artery. So that's what has happened. And the second one, and this was another disastrous case. This is the case is the most important case in our institution, and we have one of our senior colleague, Dr. Lakshmi Das. He is a hardcore femoralist. And we never does radial. Even we do radial also, if we have to do a femoral, then we have means PCI. The radial access will be pulled out. We have to go femoral. So this is an important landmark in this thing. So this patient is a 71-year-old female, the diabetic hypertensive inferior wall thrombolized. So this one, the LAD was fairly okay, and in RC also there was a lesion. So underwent a PCI to RCA with a 33 millimeter stent and LAD with a fairly straightforward procedure. It's an obese lady who had a femoral access, and the patient went out, and within no time, they means after the sheet was removed, 2 3 hours the patient had a little hypotension, then urine output started falling because he was so obese. Nobody could observe the early hematoma, and once it started bulging in the groin, then only it was realized that he was bleeding in the groin. Then we took her back. Just see that the puncture was, because he was so obese, the puncture was somewhere here. This at the lesser trochanter level. So this is so low is a puncture, and the compression was not effective and started leaking from this side. So then we wired from the opposite side. And again, it was very difficult. So this time we used ultrasound guided puncture and entered from the opposite side. And we used balloon dilatation, and it was not helping with the bleeding. So then that time we didn't have many covered stents. So we had one 640 fluency. The fluency stent was deployed. We had only a shorter one, so that did not stop bleeding because it is smaller size and a shorter length. She continued to bleed. See here, she continued to bleed after that. Then we had to exchange for a 9 French sheath to put a bigger fluency stent. So the second fluency was dilated. So this is after first fluency. So we put a second fluency because the first one is not stopping. So it is the 840 fluency here, and dilated with a 9 millimeter balloon. After that, we could stop the bleeding. But unfortunately, patient has developed all sort of complications, renal failure, and hypotension, sepsis. We could not save this patient. So this resulted, after this patient, Dr. Lashman has become 100% radiologist. He hardly does any femoral now. And another case, this was the case provided by Dr. Sai, which is from Matthew's unit. So this is again an obese patient. Sir might remember this patient. So it is obese patient. You can just see that how bent and this access seat. I think it was a complex case, so they put a venous sheath also. They took a check shot. You just see that there was an bleeding in this obese patient. And so this was your DSA, which shows bleeding clearly here. It is coming from one of the, I think when they attempted puncturing the venous, they punctured one of the arteries here, small arteries here, that started bleeding. So then because it is bleeding continuously happening, they're given some heparin. So what they did, they came from the opposite side.
Vijay?
Yes, sir?
Vijay, can you be still more louder?
Oh, louder, sir?
Yeah.
Okay. Okay, sorry. There's only 2-3 more slides are there. Sorry. So this one, so it was just to put a propagate catheter. It is a 018 catheter, compatible catheter. Then they put 2 centimeter and 2 millimeter into 2 centimeter Hilal coil inside. So after putting this coil, the bleeding is stopped. Then they went ahead and they finished their complex angioplasty here. You can just see that this is a long sheath and a very complex left main bifurcation angioplasty was done after that. And this is one of our patients who have presented with anterior wall cardiogenic shock. So we have to continue IBP for quite some time, maybe I think 3 to 4 days IBP we have to keep. And once we removed it, the patients developed acute lower limb ischemia. And this is what we got a totally occluded femoral artery. There might have been a stenosis here that formed the thrombus, and that was crossed here. and serially balloon dilated. We attempted multiple balloon dilatations and aspiration, everything. So we could not succeed in getting the flow at all. So then we decided to put a stent here. This is one of our colleagues' patient. So this is a 7-150 Protege Everflux stent, and we dilated with the 8mm balloon. And finally, we got a good flow distally with a residual thrombus proximal part. So we just continued with anticoagulation for some more time, and she became all right. And then this is one of the rare cases. I was just talking to you about renal failure patients. Renal failure patient, and if there is no fistula, we always prefer a radial access. And if this lady unfortunately had a fistula one side that is failed, and another side there is another fistula they created, so we could not go through the radial approach. Little obese lady, and good arteries, and you can just see that we punctured through the femoral head. I only did this case micro puncture set. I used only a 4 French. Nowadays we use a femoral diagnostic angiograms with a 4 French system. So post, and she had some dissection. So then I have to take a left femoral access, and the left side we did finish the angiogram. They removed the left sheath first, the right sheath second. She had first developed a left-sided hematoma that was compressed successfully. Right side was normal. And I kept her in ICU because she looked like she's going to bleed. But exactly, she bled in the night and developed a huge swelling in the groin. And just see that this is a CT image. If you can see clearly, there's a big pseudo-donor response. Just see that this is the pseudo-donor response. The small distance here. And in the end, we just tried compressing all these things. Nothing worked out. We're not very comfortable injecting thrombus because the radiologist felt that there is two communications in this artery, so we didn't do that. And in the end, she underwent surgery, and pseudoaneurysm was ligated, and the artery was repaired. And this is another patient who had a pseudoaneurysm. You can just see that this is arterial access, and this is your pseudoaneurysm cavity, and this is the flow into the aneurysm. And we just used ultrasound probe compression, and in the end, the aneurysm was successfully compressed. And to summarize, I didn't have many pictures for retrograde dissection. We had few, but the last 1 week, I could not identify one. Then other complication is just arterial venous fistula. These are the things, again, you have to keep in mind. So to summarize, optimal femoral access is the key to success of many complex percutaneous interventions. Many femoral access site complications can be avoided by proper access techniques. Always presume that access site will be managed by manual compression alone. And early recognition and optimal management of complication is important to prevent adverse procedural outcomes. Thank you so much. Maybe I think Matthew sir can add a lot of things to this presentation.
Thank you, Vijay. Deepak, what is the plan? You want to discuss the femoral access now, or go
yes,
on?
Sir. Yes, sir. We'll have some discussion because there are a few questions also. So we'll have a discussion before we move on to the next topic.
Go ahead. I have been seeing a lot of comments from Natarajan in between. If he has to make any comments, or anybody else want to comment or take up the questions, then.
Yes, sir. Sir, one question is, why pulse pressure is a contraindication for femoral puncture? Can Vijay take it up?
Yeah, this the pulse pressure is the one which decides your pulsatility of the artery. So particularly when you have this renal failure patients and the aortic regurgitation, all these patients, they have wide pulse pressure. They are prone to develop bleeding complications. So whatever femoral complications we had so far, most of the patients were renal failure with fistulas. So these patients will have some platelet abnormalities and wide pulse pressure. And again, aortic regurgitation and other patients with wide pulse pressure, they always have a higher tendency for bleeding. Even when you touch, when they puncture, the way it pulsatile, that looks like it's going to burst at any time. So what is your take, sir, on this, Matthew, sir?
I agree with you. Wide pulse pressure generally have got a higher tendency to bleed. But that is not a contraindication. But
it is not a I told you it is a relative. You have to take more care in doing that. And unfortunately, most of these renal failure patients will have some calcium and other things. You can't use an access closer also.
The question is, I am more scared of people who have got very, very superficial femoral artery.
Yeah, no subcutaneous
palpable, and actually, thin person, you will feel that you can have a hemostasis very easily.
Yeah.
That is the one generally tends to bleed and bleed and bleed. We underestimate the possibility of the
because you need subcutaneous tissue.
Lack of subcutaneous tissue is very, very important issue. That also we should be very careful.
Careful in that. Particularly thin elderly ladies.
Yeah. Then I just now saw somebody asking a question. Vijay, you should answer that. I don't use ultrasound at all, except in aortic tower. Yeah. So they're asking whether the cardiac probe can be used for.
No, it doesn't work well, sir. You need a linear probe. It is available. So what they use in our OPDs and other places for doing carotid Doppler and other Dopplers. But there are dedicated systems. Sonocyte is the one system people commonly use it. And this is a GE system. V-scan is a very nice one. So the probe on one side you can do echo, another side you can use a Doppler. So this is the one we commonly use in our cath lab for doing our access and emergency echocardiogram. It's a very nice handheld system. And there is another thing, dedicated systems are available, Sonocyte and other systems are available.
Another thing I wanted to point out was just screening, seeing extensive calcification of the femoral artery, that also you have to be extremely careful.
Extremely careful. I mentioned that.
Give us lots of trouble. Preferably, you should use a closure device in those patients because they tend to bleed, because once it is calcified, those vessels, the elasticity is almost lost. They generally don't close well, like in the case of renal failure patients. Both of them, preferably you should use a closure device. I wish we had some time to discuss closure devices also, because that is in very, very regular use in many of the labs. The commonest available closure devices are Angioseal and Perclose.
So what is your preference? It is renal failure and other patients, you use a Perclose or Angioseal? Because most of them, they have calcification. The needles are very difficult to put inside.
That's
so
right.
Sometimes they just tear and come out.
Perclose, or the present device name is Proglide.
Proglide.
If there is calcification, Proglide also tends to give us some problem, because when you take the suture line out, those needles get stuck in the calcium. And I have quite a bit of problems with Proglide also. Angioseal is all right, but it tends to ooze all around.
Yeah.
There is no hard and fast rule, but whichever you are familiar, you should start using the Proglide and Angioseals, because you need to be familiar when you to deal with the cases where you find there is a problem. And when you hematoma before the end of the procedure itself, that means they are the ones likely to give us trouble. It may be safer to use one of these devices and close it off. Proglide, one advantage is that even if after closing, if you keep the wire access open, even if there is some bleeding, you can use Angioseal onto that, and the combination can very often stop all bleedings.
Yes. The worst thing is this renal failure patients, you do angiogram or angioplasty, then the same night or next day morning they dialyze. That is when they bleed.
Yeah.
And they use heparin. If you don't tell them, they just use heparin in that. So they started bleeding.
What are the other questions, Deepak? Any questions came up?
Sir, another one suggestion, a question from Natarajan sir. Matthew sir, have you ever switched to, having done so many thousands of femoral punctures, have you switched over to the radial approach? And have you, having said so, would you suggest, at least in one particular scenario, you would always prefer you going through the femoral approach, like doing a rota, like doing a left main bifurcation stenting? Would you suggest to the younger crowd which situations one should prefer going through the femoral approach rather than being a radial fanatic?
I think I will ask Shiva to answer the question.
Yeah.
I'm not a great fan of radial. I'm not a radialist at all. 80% of my cases are femoral, and I continue to prefer radial. Main reason may be selfish. I would like to stay away from the X-ray as much as possible. Second is, I became so familiar with femoral artery. Our complication rate has been so minuscule, not even 1%. If you look at an average, any bleeding complication or any complication related to that. So I wouldn't be able to comment on when would I switch to radial, because I'm incompetent to comment the advantages of radial when compared to femoral. Femoral access always gives me a lot of comfort because we have lots of various guiding catheters available for intervention. The choices are unlimited, and your familiarity with the devices are so much easier. So it is easy for somebody who have been used to femoral to continue to use it. Shiva is a very staunch believer in radial, and he is able to comment on that. Natarajan, I think we will leave that question for Shiva to address during his lecture.
Yeah. Sure, sir. During my talk, I will do that.
Okay.
Sir, one last question. Sir, one last question, sir. Matthew, sir.
Yeah, go ahead.
Sir, while doing an intervention through the femoral procedure, let's say you encounter a patient with hypotension halfway through. You know that no harm has been done to the coronaries, and you feel that something has happened to the groin also. So what would be your next step? Would you immediately image the groin? Would you start Brady with hypotension? What all steps would you take? Would you start them on fluids, noradrenal, and atropine? What would be your next step? Let's say it's just a vasovagal syncope, but still, what are the things you would that would go through your mind?
See, if I am not already committed to the interventional procedures and have not started dilating already, I have time to concentrate on the groin. I would prefer to, even if I wired the coronary and given full dose of heparin, I would leave the wire there and come back and have a look at the femoral artery. Very often what you can do is, if you are suspecting that if there is any bleeding or not, you can inject through the side arm. It's not very efficient, but very often you may be able to detect any bleeding. If there is any counterpuncture or you have had a small dissection, some complication. Very often you did not have any procedure, any difficulty getting the wire in, sheet in. It happens is in the people who are obese. The sheath kinks at the entry site. When it enters the femoral artery and your puncture direction is not exactly 45 degrees, it tends to kink at the entry site. And that can keep on oozing and giving you a hell of a lot of problem. You will find it very difficult to circumvent that. In that situation, I would like to ask one of my assistants or the scrub nurse to come and press the groin and hold. Very often, you can escape and complete the procedure by doing that. If still we have problems, we manage whatever procedures we have to do in any hypertension, what we would do otherwise. There is no separate dictum. If there is no other bleeding at the site, the management has to be exactly same as what you would do otherwise.
Yes, sir.
Then once the blood pressure comes up, you complete the procedure. If you still the blood pressure is low in the 70s and 80s, I think you should abort your intervention, come out, take care of the groin, find out the problem, look after that, and reverse the heparin. you have all the liberties to do all that, reverse the heparin and take care of the groin and bring the patient back on the next day or after a few days and do it. Don't be too aggressive and too greedy to complete the case that day. It's better to commit ourselves and talk to the patient and family that this, yes, there is an issue. I am not proceeding because the life of the patient is more important, which I cannot give it back. It's safer to not to proceed with the intervention. Otherwise, you can go into lots of trouble. Post-intervention, if patient continues to be hypertensive, you can have stent closure, thrombus formation on the stent, various problems in the coronaries also. Don't do that. Step down and accept that, yes, we have limitations.
Yes, sir. Sir, also, would you have a look at the bladder, the indentation of the bladder, even halfway through if you encounter a hypotension, just
Of
to...
course, Deepak, that's correct.
Thank you so much, sir. Thank you.
Thank you, Shiva. Very, very nice.
Sir,
Vijay, sorry.
sir, no problem, sir. Sir, just I have to leave for another thing. So thank you so much, sir. Thank you, Deepak, sir.
Okay.
Thanks.
Shiva,
Vijay,
sir, thank
so
you. Bye,
much.
sir.
Thanks,
you, sir.
Vijay.
Shiva, let us
Yeah.
hear from the ardent radialist. Let us hear from you.
Right. Thank you so much, sir. Hope, Deepu, are you able to see my screen?
Yes, yes,
Yeah. Hope I'm audible.
yes.
Yeah.
With all respect to Dr. Matthew, father of interventional cardiology to this part of the world, and my fellow speakers, Vijay, Girish, and happy to be with Deepak today, and thanks for the invitation. And out of all the webinars I attended in pandemic, I think this is the one which is touching the basics, and sticking on to basics will definitely save your day. And having said, agreed with Dr. Matthew that the complications are less with femoral, but even though it is less than 1%, but I started my interventional career along with the primary PCI, more in patients with the cardiogenic shocks, that too with the loading dose heparin, 2B3A blockers. So we had untoward incidents like retroperitoneal hematoma and acute limb ischemia in an otherwise smooth, uncomplicated coronary intervention where we had morbidity and mortality. That led us to definitely looking for a change, and this change happened to us somewhere around 2007, if I'm right. And by the time Rajpal was doing radial at Coimbatore and Sangatwell started in Chennai, and we do attend meetings by ferry along with the first assistant of Mary Claude Morris at Nizam. There was a focused radial course were conducted. Then I had stay with Tejas Patel in his place for a week. And this is how I started. There was initially a lot of hesitancy when I was shifting from femoral to radial. There was a long, steep learning curve. And in fact, initially we were doing only diagnostics. And definitely there was a long gap between diagnostic to getting into the guides. And once it happened, now it is 100%. It's routine. Once we get an access, we don't think of the access, what access we are in. We just carry on with the procedure. And let me start with the pre-procedural planning. And we all know that often this is asked about Allen's test, but I don't do. I'm sure majority of us radialists may not be doing it, but I took a reference. Is it still meaningful? But when I took a reference, look at the three graphs. Each graph is speaking for capillary lactate and hand grip strength and then ischemia, that is tolerance. There are three groups: normal Allen, intermediate Allen, and abnormal Allen. But the difference, there was no great difference between the normal and abnormal pre-procedural Allen. Doesn't predict the differences in thumb capillary lactate, grip strength, or ischemia. Based on which the definite recommendation, at least if not for all, at least for ACS, there was an earlier approval with the class 1 recommendation with the level of evidence A, radial first approach, but you need to have a good operator experience, a good volume when you pursue in ACS. And non-invasive testing, like I mentioned, Allen or Burbue, doesn't predict adverse outcomes and need not be used for access site triage. Regarding radial first versus femoral, radial first is always give you a great comfort to the patient, less bleeding. Patient can be discharged on the same day, even for an PCI, whether it is simple. Recently, Sripal was presenting a left main radial discharge on the next day, and no need to compress the groin. And of course, the overall cost, because it reduces the hospital stay, so the cost comes down. Addressing K. Nararajan's question, when will you go for femoral first approach? I think in CTO, even if you're a radialist, for a contralateral approach, you need a femoral access. You call it as a combo technique. So one would also know, one should always know how to clean puncture a femoral artery also by the various techniques explained by Vijay. And when there is a need for a hemodynamic support device, for example, in a primary PCI or in a severe triple vessel LV dysfunction where you want to put an impella, radial access, but for a hemodynamic support device, you need a femoral access. And in an extreme arterial luxuria, having got an access, having taken the catheter, but arterial luxuria is not allowing it to access into the coronaries, where one will look for femoral access. And these are the various trials based on various trials like matrix trial, raffle trial, ravel trial, and semi-radial trial, based on which there is a comparison between femoral and radial, where the access site bleeding is less with radial, arterial complications are less with radial, patient comfort is great, and immediate ambulation. There is a need for closure device in femoral, where it's just a band in radial. Of course, initial phase, you get into more radiation, longer time in lab, for even for a diagnostic, but later on, once you process the learning curve, it comes down. And of course, when you want to access the lemma, it is difficult from the right radial. Of course, one can choose left radial in that case. And learning curve is quite long. And for bigger devices, it is always a challenge, as said by Dr. Matthew. And of course, when there is a peripheral vascular disease in obese individuals, definitely radial is a choice. What do you mean by difficult radial access? When you stick the site too distal, closer to the wrist, naturally that's a tough access. And when there is a very lean individual, when there's a thin caliber artery, particularly with the woman undernourished and lean, then you can't counter and you get a spasm. And when there is an anxious patient, when there's a pre-procedural spasm, and moment you put a wire, when the wire decides, then you always it's tough. And this is always a case. I remember still one of the lectures, Dr. P.C. Rath was presenting his 100 cases of only ulnar approach. And I do ulnar not as a first choice, but when this particular slide speaking for a comparison between ulnar versus radial, but it is still radial is better in terms of lesser spasm and lesser access site complications. But however, ulnar is straighter artery, lesser loops, but it is deeply located. So once you get into the ulnar, the drive-in is easier, but being in a deeper structure, there is a chance of more hematoma. And this slide again says, when they allocated between radial versus ulnar, there was significant crossover from to radial from ulnar. So basically, one would always prefer a radial. If you fail, then the next choice becomes ulnar. Even though it is straighter artery, lesser loops, being deeply located, there is more chance of hematoma, and it is not spasm free like ulnar, equal to ulnar. So this is ulnar. When both radial artery fails, the nerve is lying very closer, so you may hit the nerve, and the puncture site will be little more proximal, unlike the radial, to the styloid process. And this is another interesting. This is based on a trial called SHIP trial, various other trials too. On the same day, for some reasons, it happened to me. You will be doing a diagnostic. You would have removed the sheath. By the time the family will tell, we are now willing, go ahead. So can we on the same day, on the same time, on the same patient, immediately after accessing the radial, can we do the ulnar? Initially, there was hesitancy. People used to tell, no, you will disturb the palmar arch. If you even puncture, you not even wired. Once you punctured, you should not touch the ulnar because of the belief, all the belief on ulnar, Allen test, all that. But clearly the trials have shown, even after that, I have also changed. On a day where you have hit a radial artery, where you failed, you can, on the same side, ipsilateral side, you can go ahead with ulnar and you can complete the procedure. Nothing happens to the fingers. And regarding right versus left, it is always for the physician comfort, it is right radial, but left radial is like femoral. The point of resistance is only at one level. After crossing this level, it becomes like a femoral. Whereas in radial, right radial, the point of resistance is two. One is from the right radial when it converts into the subclavian, then when subclavian descends to the ascending aorta. So there are two levels of resistance. So naturally, right radial is a bit demanding. And when they compared left versus right in terms of procedural time and radiation exposure, the left radial, as I said earlier, left radial, once you cross the arch of aorta, it is like a femoral. So there was less fluoroscopic time and less procedural time. But however, it was very demanding to the operator as well as to the patient in terms of comfort. Particularly, radial failures are common when you are dealing with advanced age patients, female sex, short stature, and hypertensive population because of the diffuse nature of the artery. And this is most important. You need a setup, you need a board, arm board. Each lab can design it. Nowadays, the labs are coming with inbuilt arm boards. This is most crucial for the patient comfort to keep the arm comfortably placed. And this is how it is. This is a distal palmar arch, and this is a styloid process. You go well proximal to the styloid process, and this is how the radial artery runs. And the bifurcation somewhere forms at the level of cubital, whereas in ulnar, it is just parallel to the styloid process, just above the wrist, and it is straighter, deeper, and it meets the brachial there. And let me play the. Yeah. Once fentanyl is given, I don't give midazolam anymore because of the respiratory issue. I use the insulin syringe, 1 ml syringe with the insulin needle, and along with the, after palpating the styloid process along the radial artery, I give it, then puncture, counter, pull it back. There is a pulsatile and jet flow, and you wire it, and the sheath is in. Once the sheath is in, the already prepared cocktail, I now use only heparin and NTG, mix it with the blood to avoid the burning sensation. And you subsequently sheath in whatever you want, whether diagnostic or guide. And this is regarding dorsal or distal left radial access. Some radialists do. I have not done much. This is basically for the comfort of the physician as well as for the patient, particularly for the left radial, where you can keep the arm over the abdomen, and it will be very comfortable to the patient. You need to puncture at the anatomical snuff box, where there is no risk of compartment syndrome. And while putting a band also, there is a fulcrum around the thumb, which is closing the artery well, and the risk of radial artery obstruction also, they say, less. Basically, the dorsal radial artery or distal radial artery in anatomical snuff box is done for better ergonomics for the operator and patient comfort, lesser permanent occlusion of radial artery, lower rate of compartment syndrome. However, it is smaller in size. You may have to take the help of ultrasound. There is a learning curve. And regarding radial artery access with ultrasound, I don't do this, but definitely worth knowing, because in patients with the cardiogenic shock, where definitely there are 3 areas where radial is definitely have an edge over femoral in terms of mortality, like ACS, particularly primary PCI, another is AKI, Another is cardiogenic shock. So in situations of cardiogenic shock, definitely when you are not able to feel the pulse, this ultrasound guided, this graph tells you that in terms of number of attempts, first pass success, in time to access and difficult access, definitely ultrasound guided radial puncture compared to palpation guided radial puncture made things easier and quicker and successful. And this is how it is. You can hold the probe in your hand with the covered for the sterility, and you are seeing the artery. It is a not only pulsatile, there is a phasic Doppler signal. You are puncturing it, seeing, sound, listening, and you are puncturing and you are putting a wire and you got it. So when there's we all know there's a spasm is an issue. We all know the methods to relieve the spasm. But when there is a refractory spasm, it is not just spasm. That this time you have to think of radial loop, recurrent radial artery, or high bifurcation. Here is a case I can demonstrate you. There is a loop as well as there is a recurrent radial artery. This recurrent radial artery is quite common. During our early phase, I was not able to understand what is happening here. Sometimes a diagnostic catheter will catch this recurrent radial artery, will go all the way, will finish the diagnostic angiogram. By the time patient is willing, when you want to do the PCI, the thing will not go. Then that point of the time, we realize we need to take a help of contrast. Moment there is a refractory spasm, nothing is progressing. We need to steady the vessel. You will see one thin artery running straight without forming the brachial artery. That's a clue. Because if you track over there, there's a risk of perforation. You may not track, and you need to bring it down your catheter. If there is a loop, it is associated with the loop or without loop. If it is with the loop, you have to go to the loop and reach the brachial artery. If it is without loop and you have reached the radial artery, bring it down and reach the brachial artery, and it simply works. Without knowing this, now if you take balloon assisted tracking, then it will not progress, it will cause perf. So in every case, when things are not progressing, don't push your things. Make sure you are not dealing a case of recurrent radial artery, because this is not uncommon. Now, another situation will be where there is a high bifurcation of brachial artery, that so-called ulnar radial artery summit, which usually happens in the cubital fossa, sometimes happens in the mid-humerus, where till it reaches the mid-humerus, where the bifurcation is happening, summit of bifurcation is happening, the radial artery will be a smaller chamber. Generally, radial artery compared to ulnar, it is smaller. That is why ulnar artery, there is a fancy about it, but it is being deeply located. When situation is like this, high bifurcation, when the radial artery is running up to the mid-humerus with a lesser caliber, then again you are prone for spasm, where you may have to resort for a different technique like balloon assisted, all those kind of stuff. So how one can cross the loops? Use an angled guide wire or thermo wire. I always use a coronary wire. I have a less threshold to move it to the coronary. The moment I have a problem, I just immediately take a coronary wire. Then I take a taiga with a coronary wire, or you can take a 5 French new tiger. You cross it, and once you cross it, you can change the wire, and you do a counterclockwise. Then you unloop it, pull it back. You will unloop it. But in spite of it, there are certain loops which will be very, very demanding. You may not able to cross the loop. Sometimes you will cross the loop, but you will not unloop it. There's no other choice. You need to transfer to the left radial or femoral. And this is one case. You can see now there is a loop, and nicely the catheter got in. Probably they changed to a stiffer wire. Now they are pulling it down. You can see now it is getting unlooped, and subsequently you will be there. So yeah, see there is a nicely. Sometimes the moment you keep feeding the stiffer wire, automatically the loop will get unlooped, or you may have to do a manipulation which unloop it. And this is a situation always encountered by any radialist. I have encountered this once without knowing what is happening. When you keep on pushing it, because of the razor effect from the guide or catheter diagnostic tip, there is a puff. There is a, when you inject a dye, there is a extravasation of dye. But the point is, don't panic. This I learned from Tejas, that when you have a puff in radial, this is the time you have to persist to be on radial, because you complete the procedure on radial. The dwelling of your catheter itself heals it. Don't pull things. Make sure you get that done and finish the procedure, because the internal tamponade will seal the perfusion. This is the time. This is how the perforation has happened. The razor effect caused by the tip of the guide or the diagnostic. Then subsequently, you put a wire in. Sometimes I always coronary wire helps here. Then you bring a balloon. Half of the balloon is inside the guide, half is outside. Now you push it nicely. This is many a time helped us. This after we learned from Tejas, when we started applying, this really worked for every colleague of us. And this really, in a tough case, in case of spasm, in case of hypoification, in case of PERFs, where once you are made it sure this is not recurrent radial artery, this balloon assisted tracking definitely helps. This is how it is. You wire it, take the balloon and keep it bit outside, off in, off out, and inflate to 4-5 ATMs, and keep tracking the guide, the diagnostic, the guide over the balloon. Then next problem comes the subclavian tortuosity. What you have to do is take a low profile catheter into the ascending aorta, then exchange the softer wire to a stiff bodied J wire, and keep the stiff bodied J wire for support during catheter and manipulate. So like that, as I said earlier, in loop, radial loop, similarly in subclavian loop or subclavian tortuosity also, moment you put a stiff wire, keep feeding into the ascending aorta, it most of the time goes away, or ask the patient to take a deep breath and do some kind of a manipulation which will unloop it, and you will get into the ascending aorta. This is another situation where there is a difficulty which I call it as arterial lusoria. By definition, it is right subclavian artery coming distal to the left subclavian artery. It's aberrant right subclavian artery which arises distal to the left subclavian artery, where the access is not an issue. Getting into the ascending aorta will be an issue. Even after getting into the ascending aorta, getting into the coronaries will be definitely demanding. So sometimes in extreme arterial lusoria, we have changed it to femoral or left radial. So regarding tackling spasm, we all know the cocktail agents like I don't use verapamil. I don't use, rarely I have used after NTG, which is not happening. We dilute the lidocaine and give a little over the sheath. It sometimes works. And sedate the patient, talk to the patient, explain to the patient while preparing the arm, keep his comfort level to the maximum, and allow the time to allow time for the spasm to relieve. When there is a spasm, just wait for some time, it will go off. And you can definitely look for downgraded sheaths and catheters, and there are choices like inversus catheters, which I will touch upon later. Regarding engagement of the guide, I think definitely Deepak also will be touching on this. For the RCA, if there is a too much deep throating, you need to, during clockwise, you need to, because like in femoral, like 1.5 movement in radial, because it moves as a one big assembly. Moment you give a torque, it will deeply engage, particularly when there is a block in the proximal RCA, you may dissect. So moment it is getting engaged, you need to do a counter movement. For the left coronary, I think if the catheter is in the right cusp or non-cusp, pull back and counter clock and swing it to the left cusp and push forward so that nose points up. If the catheter is below the left coronary artery, do a counterclockwise and it moves up. If the catheter is above the coronary, left coronary, clockwise, it moves down. I think these are all, rather than telling, when you start doing, you will learn this art. And similarly, for the diagnostic catheter engagement, this is the best way to go. You fold it. If it sometimes it spontaneously folds, once it folds it, do an maneuver which it faces to the left, and once it faces to the left, it can be applicable to the guide also. You put a wire, when it is very closer to the LV, it enters into the LV. When it is very high up, it doesn't open up. When it is exactly at the level of ostium, it gets into the coronary. Sometimes we need to change the catheter too. And this is interesting, 5 French, 6 French, 7 French. We all know that it all speaks for the outer diameter, which is 2.2, 2.5, and 2.9 respectively, whereas the inner diameter will be 1.7 and 2 and 2.3. So that means for a 7-point French sheath, which has an outer diameter of 2.9, in the internal diameter is only 2.3, you can allow a guide which is of only 2.3. That means a 7 French guide, 7 French sheath taking a 7 French guide will be demanding. So in a 7 French guide, the ideal will be 6 French, because 7 French becomes 2.3, almost equal to 2.3. Based on which the thermo people have invented a wonderful technology, which I have used, which has helped me in complex bifurcations through radial. We call it as 6 in 5, 7 in 6. That is, the outer diameter is like 6 French, but the inner diameter is allowing you to take a 7 French guide. And K. Narajan asked when you will go upfront 8 French. Of course, in 6 French system, when there is no tortuosity, when there is a simple bifurcation, no big balloons or 2 stents are not handled simultaneously, when there is no much calcification, and we can work in a 6 French system. In a 7 French, when there is a complex bifurcation, when you are dealing with 1.75 or 2 bar, I think you need to. So when you ask me, in radial, for rota of 1.75 and 2, I will go for either 7 or 8. Otherwise, most of the procedures can be carried out, even a bifurcation, even complex decay crash, because except SKS and mini crash, most of the other bifurcations are stent after stent, so one can get away with French. Otherwise, also, as I said, the thermo 7 in 6 will help you with outer sheath being 6. This is regarding how to get in the RCA. We all said RCA is like similar like femoral. Oh, my connection is unstable. Is it okay now, Dibu?
Shiva, the slide hasn't changed.
Oh, okay. You can use a jerkin right or hockey stick. Is it okay now?
We are seeing the rota slide.
Oh, right. You're seeing the rota slide.
But we can hear you clearly.
Is it now okay? Is it moving now?
No, not yet.
Let me off my video so that I can see.
Shiva, by the time you can you hear us? Can you hear me? Yeah, by the time Shiva you get ready, there was a question on arterial lusoria, Shiva. Like how do you manipulate the catheter into the arterial lusoria? Primarily, it's like you're working with a diagnostic catheter. Probably you're having a tiger catheter with you. Get the tiger catheter till the tip of the subclavian artery, and the catheter will be pointing towards the descending thoracic aorta. Now rotate in such a way that it points upwards towards the arch of aorta, and then remove your O3, whatever, O36, O35 wire, and go with a Chermo wire, so that when the tip of the tiger catheter points upwards into the ascending aorta, you can easily manipulate the Chermo wire into the ascending aorta. Then over the Chermo wire, you can ask the patient to take a deep breath and then push the tiger catheter into the ascending aorta. Engaging the right coronary artery is always easy with arterial lusoria, but then engaging the left system would always be challenging. So you have to make them hold the breath again and again so that you'll be able to engage. Now getting the guide catheter into the ascending aorta, always you need to exchange with the 300 centimeter wire. Keep a long 300 centimeter wire in the ascending aorta, and not exactly a very stiff wire. Probably a regular O35 wire would be fair enough. Then over this wire you could go with the guide catheter. Regarding guide catheter, a regular jerkin would be easy to engage the right coronary artery, and regarding engaging the left coronary artery, a regular left jerkin would easily engage the left coronary artery. But then the challenge with the Judkins guide catheter would be you might not get a good backup support for for a difficult lesion, when you have a difficult lesion, getting the balloon across, tracking the stent, the support may not be good with a left Judkins catheter. So you might have to, when you have a difficult lesion, one might have to try engaging with the EBU catheter. Again, EBU catheter, when you go through an arterial lusoria, normally if you're used to using a 3.5 EBU catheter, in this particular situation, try using a 3-curve catheter. Go to the aortic root and make a proper curve. And when you make a proper curve, you have a new curve, and then go through the catheter, straighten the catheter with the back end of the 035 wire, so that you might be able to engage the left coronary artery. So engaging the left coronary artery with an EBU catheter is always challenging. And once you engage it, you have a good backup support, even in an arterial lusoria. Shiva, are you ready? Shiva? And also one point mentioned by Dr. Shiva regarding the bifurcations. Matthew Samuel sir, we radial fanatics, few of us try to do bifurcations through the radial approach with 6 French guide catheters. When we want to do kissing balloon dilatations in complex lesions, 8 of the 10 cases would go on well without any challenges. But then 2 out of 10 will always be challenging. So every time we get an opportunity, a good patient, a good femoral artery, we try to do a bifurcation, through a true bifurcation, a complex bifurcation through the femoral approach. And only simple bifurcations, when we are almost sure that we are going to get away with easily, we try doing through a femoral approach with a 6 French guide catheter. And every time you try using a 6 French guide catheter, it has to be a New York guide catheter, so that you can easily take 2 balloons without any kink in the guide catheter. Sir, Matthew Samuel sir, when you do bifurcations, at least through the femoral approach, have you, in situations in very, very skinny ladies, do you try doing with a 6 French guide catheter, or is it always a 7 French guide catheter when you go for complex bifurcations?
Deepak, am I audible?
Yes, sir. Yes, sir. Yes, sir.
Okay. I would prefer to go with the 7 French in majority of cases, because that gives me a lot of liberty, especially when you are on a femoral. 7 and 6 doesn't make any difference.
Yes, sir.
So always better to have a guiding catheter which is larger lumen, which will provide us a lot of opportunities to change devices, have multiple devices also. So I wouldn't compromise on that.
Yes, sir.
Only coming to the point which you are talking about, the arterial lusoria, I thought very often when it comes to the left, as you said, the right is very easy, left is usage of guidezilla or guideliner.
Yes, sir.
Eases out the whole procedure. Even if the guiding catheter is not sitting in the ostium of the left main, you
Yes,
can
sir.
engage it with the guideliner and get the patient treated very easily. So
Yes,
it
yes,
is worthwhile getting used to usage of guideliner. It's extremely useful device, especially in difficult situations.
Yes, sir. Yes, sir. I would definitely agree with you, sir. The situations wherein we have tried with an EBU guide catheter to engage into the coronary after making a U loop and the ascending aorta, when we try to get the back end of the guide wire, when it reaches the arch, what happens is many times, because of the push of the back end of the wire, the curve there, it makes the catheter prolapse into the descending aorta rather than getting into the ascending aorta. So it's always challenging to get the EBU guide catheter engaged properly in situations of arterial lusoria. Definitely, we would agree with you, sir. Guidezilla would save the day when we engage with a Judkins catheter.
Yes, Shiva, ready? If not, I think we'll, for want of time, we can go to Girish and listen to him, and then we can ask Shiva when is he ready to complete the rest of his presentation. Would that be all right? Or?
Sure, sir. Sure, sir.
you decide whichever way you want. We can.
Yes, sir. Dr. Girish has already started sharing the screen. We're seeing the slides also.
Thank you. Thank you, Samuel, sir, for really moderating this session, and Dr. Deepak for inviting us. Dr. Samuel, sir, is like Lord Ganesha to us. So he knows everything, he's seen everything, and we just want to scrap on him every time we have an opportunity. Thanks for creating this, Dr. Deepak. And I've been.
You are very kind, Girish. Don't little.
Thank you, sir. I think guide wire is a little boring subject because it is less of animations and more of theory. But today, as Samuel sir was saying, people without understanding the construction of each of the hardware, most cardiologists perform many interventions with very little knowledge about what is the basic structure, construction, and utility of each of the hardware that are available in the armamentarium of interventional cardiology. And I've been asked to speak about the angioplasty guide wires. I think if you have selected your guide catheter correctly, the most second important thing is to choose the guide wire. These two together, if you have chosen a right guiding catheter for a support and adequate visualization, engagement, and coaxiality, second most important thing is the guide wire. So what are the functions of the guide wire? You need to track through the vessel depending on its anatomy. You need to access the lesion, whether it's in the proximal, mid, or distal, at a bifurcation, whether it is tortuous, calcified, fibrotic. So depending on that, you need to choose the wire. So it's important to access the lesion. And then after entering the lesion, you need to exit atraumatically without causing dissections or perforations. And finally, the guide wire needs to give you support to take your subsequent devices like balloons and stents. So this is the basic function of a guide wire, the purpose. Now, for this, we need to understand certain fundamental things. What are the characteristics of the guide wires that you would like to have? One wire would not have all these characteristics. That's why, depending on your vessel anatomy and the lesion characteristics, we need to choose. So what are the characteristics? One is the torque control. What is the torque control? It is the amount of rotation that you give at the proximal end and how much rotation happens at the distal end of the guide wire. That's called torque control. That's force transmission from proximal to distal end. Next one is called trackability. It's the ability of the wire to follow the wire tip around the curves and bends without bucking or kinking. Trackability means it needs to take the shape of the vessel without kinking or buckling. Next is steerability. It's the ability of the guide wire tip to be delivered to the desired portion of the vessel. Means, in spite of the tortuosity, in spite of the calcified lesions or acute bends, I need to finally take the wire to the distal part. That is the steerability. Next comes the flexibility of the wire. It's the ability to bend with direct pressure. So when you apply a pressure, it needs to bend and take that shape and go. And then comes prolapse tendency. The wire has a tendency to prolapse. What do you mean by prolapse? I'll show you some images. It's the tendency of the body of the wire, not the tip. Body of the wire not to follow the tip around the bends. You know, the tip has about distal 30 millimeters and then there is a body. So this body, does it go along with the tip? It's like a tractor, the engine of the tractor and the trailer of the tractor. Do they both go together? If don't, then it's called prolapse. Then is the radio opacity and visibility. These are very important when you're doing very complex lesions or chronic total occlusions. You need to see what is happening to the tip of the guide wire. Is it in the lumen where you want? Has it migrated outside or has it got deformed? You need a good radio opacity for the visualization. And next most important thing is the tactile feedback. When I pass the wire from the proximal end, I need to feel what is happening to the tip of the wire where it is in contact with the vessel wall. I need that feeling. That's called tactile feedback. The better feedback, then less chance of perforation or dissections. And then there is something called crossing. Crossing of the wire means it's the ability of the guide wire to cross the lesion with little or no resistance. So it should just slip through it without touching or penetrating any of the intima. And then lastly comes the most important when you're doing little tough lesions is the support. It is the ability of the guide wire to support passage of another device or a system, means to taking a stent or a rotablator or a microcatheter or a stent balloon. That is called the support. It is not anything to do with the wire, but what can be carried on the wire. That is this support capability of the uh, wire. So the characteristics of the wire have multiple, about 9 of them: torque control, trackability, steerability, flexibility, prolapse tendency, radio opacity, tactile feedback, crossing, and support. Please spend a little while to understand, and each of the wires that you already have on your shelf, where do they fall in terms of their steerability, torque control, prolapse tendency, so that you can choose correctly. So now, when we look at the guide wire building, it has 6 components. 3 are with the core components and 3 are on the external components. Core means the inner part of the guide wire. The core material is important. It is either stainless steel or high tensile steel or nitinol. These are the common materials used. Then there is something called core diameter. The larger the diameter, there is more weight at the tip of the wire and less prolapsing of the wire. That is the core diameter. And third one is the core tapering. The core inside, does it carry the same thickness till the tip? If it does, then it has a lot of penetrability, but less of steerability or less of slipping through a lesion. But when the core tapers, it can track the micro channels and it can exit. So core has 3 things: what material it is made of, next what is the diameter of the core, the thicker the core, it can go through most of the lesions. Third, as it tapers, it allows you to track tortuous lesions, or the tortuous lesion, not the vessel, tortuous lesion, or where there are microchannels. Now, coming onto the surface, external components, apart from this core, which is their steel wire or a nitinol wire, you have coatings on top of them. That blue color thing that you see, there could be hydrophilic or hydrophobic coatings. And then there are coils and covers that they cover the distal part of the core. These are not coatings. Coatings is only on this part, that is the more proximal. The distal parts are either distal part of the core is covered with coils or with the covers, which are PTFE and things like that. And then you look at the tip of the design. How is it made? I'll go into the details of them. Okay. For example, if I have to show you on regular BMW that we use, the core is stainless steel, the proximal segment, and the middle portion is nitinol, which tends to retain its shape, and memory shape is good. And then as it goes distal, there is a tapering. There is a 3-stage tapering of this central core, one stainless steel and then nitinol. And as it approaches the last, not at the tip, but the majority of the distal part, it tapers further. That leads to hydrophilic. On top of that, you have coating. That's the hydrophilic coating, which allows it to slip through. And this is hydrophilic, means when it comes in contact with water, it becomes like wax. But the final about 5 to 6 millimeter is hydrophobic. And this means this remains slippery, but it will not penetrate through the distal vessel, and perforation chances are less. If it's hydrophilic, the chance of perforations are more. So this is how buildup of the wire happens. So now coming to the core materials, what are the 3 types? There is stainless steel, then there is a durasteel, and then nitinol. Each one has their own advantage. If you use a stainless steel, that goes from the proximal to the distal end. This has great support. You can take even rotablator on a stainless steel wire. That is the support it gives. It gives good pushable force and also good torque. You can rotate it because there's a single shaft from top to bottom, which is stainless steel. When you use Durasteel, it is a high tensile strength. It has 28% higher strength, so it is more durable and better torque. It can turn as you turn proximally, the distal turns very effectively, and you also can see that the central core is not thin, it is much larger. So it gives you much more durability at the tip retention shape. When you come to the nitinol, unlike stainless steel, it is more durable and it can be used for multi-vessel or multiple times in India, you know that. And it has excellent flexibility and steering. Because it's nitinol, it can go through bends and the tough lesions. And the durable tip shape retention means once you shape the tip, it is retained probably for next 30-40 minutes while you're taking out, repositioning, or going into multiple branches, it still retains. That is the beauty of nitinol. It has a memory. Looking at the core diameters, when the core diameters is thin, there is a better distal access. It can go to the most distal vessels, and the contrary, because you access that, you lose support. Since the thickness becomes less, the support means taking a bulky device on the wire becomes less possible. When you take a larger diameter, that means more support and more torque. It turns very well and it holds on to that. So if you're treating very proximal disease, you should use larger diameter, more support and torque wires. When you're treating more distal lesions, you should take something which is more flexible. So what I mean by that, this is what it means. When you look at the core is uniform and large and tapers a very short distance, the body tends to follow the tip, right? It does not prolapse too much. But if you have conventional tapered core, means at multiple areas it is tapering, and there is a big joint where there is a thick portion of the core, and then there are thinner portion. Every time you push the wire, the tip enters the lesion, but the body does not follow the lesion. So the wire keeps prolapsing. So in these situations, you must not use regular junction wires where there is thick and thin core are attached, because body is not going to follow the tip. Choose a guide wire which is tapered uniformly without sudden transition in the diameter. Then the body follows the tip, like in the proximal plate. And also, when you look at the core, this I was talking about transition, the thickness, diameter of the core. Now I'm going to the core tapering. You can see here the longer taper, the tip gradually tapers and it's narrow over a period of long distance. Here, the body tends to follow the tip much more easily compared to there's a shorter transition between broad segment of the core to a narrow segment of the core. So always choose when you have acute angulation, like you have a left main to circumflex lesion where circumflex originates more than 100 degree and there is an ostial circumflex lesion, exactly the way it is shown here. Regular wire is not going to follow. You need to find a tapering core and also probably a much broader core. You need to choose a wire which has this. I will show you. This is just for elucidating it. Now, coming to the coatings of the wire. Coating means lubrication, lubricity, and tracking. So when the tip is coated and lubricated, it tracks a little more challenging acute bends or lesions which are a little tougher much easily. So you have two kinds of coating. One is hydrophobic coating, the other one is hydrophilic coating. Hydrophobic means it repels water to create a smooth, slippery, wax-like surface. It repels it. So no actuation with the water required. And it reduces the friction and provides device trackability. See, when you go back to the hydrophilic, it attracts water to create a gel-like. Here it appears like wax, means when you throw water on the wax, small water droplets form and they help you to keep lubrication. But when it is hydrophilic, it absorbs water and becomes like a gel. Everything goes through it, minimizes the friction and better trackability. Then what does it differ? Then what is different between hydrophobic and hydrophilic? What is the difference is both of them reduce the friction and both of them increase the trackability, but one becomes gel like, the other one becomes like, what do you call, wax like. The difference is the hydrophilic ones, since they become gel like, they can perforate the distal vessels. So when you are into diffuse disease vessels, distal branches are small, avoid hydrophilic wires, because they pretend like they're finely coated with a gel and they can pass through the distal vessels and cause perforations. So when you handle hydrophilic wire, be cautious about distal, where the distal wire is. Now, the lubricity and tactile feedback. This is another thing. When there is a gel-like thing, you don't feel the feedback all that well. But when it is wax-like, you feel a better feedback. So when you try to increase the lubrication, there is a polymer cover with hydrophilic coating. It slips through any of most of the lesions. And hydrophilic coating alone, without polymer cover, causes a little less lubrication, but it gives you slightly more tactile feedback. And when it is hydrophobic coating, like in a BMW or something, it is less lubricated, but you get better feedback from the tip. And then there are total non-coated wires, like rota wires, where there is absolutely no lubrication, so it does not go through the lesions easily or tortuous lesions easily, but it gives you a fantastic feedback from the tip. Both of them have a role. Lubrication has a role, tactile feedback has a role. When you're trying to cross tougher lesions, you want good tactile feedback. If you don't have a feedback from the tip, you may perforate or you may dissect inside without even knowing, because the polymer coated, hydrophilic coated, polymer covered and hydrophilic coated wires can easily go into the subintima and make you feel that there is no resistance, as though you're in true lumen. But when you take a hydrophobic coating, it does not slip through a tough lesion, but it gives you a good feedback. So find something which always give you little feedback. That's why hydrophilic coating without a polymer is good. But when you have very tough lesions proximally, especially CTOs, polymer covered hydrophilic coated ones are good. If you cannot penetrate the proximal cap, at least you can go proximal subintimal and then enter back into the true lumen with exchange of hydrophobic coated wires. Hydrophilic wires will not help you to re-enter the vessel once you have exited. They're good to access subintima, but not good to come back into the intimal layer. Now, coming to the polymer covers, you can see here the full polymer cover means very slippery. We are like Pilot 200 or Pilot 100 wires. And then you have partly intermediate polymer cover, means half of it is covered with polymer and the rest half is not covered and they are exposed. They are called hybrid wires like Xi'an blue, which gives you a great trackability. At the same time, the tip does not cause so much danger and also gives you a certain amount of feedback because this is not covered with polymer. And there are other ones called bare coils. There is no polymer on the tip at all. So these are the ones which gives you a fantastic feedback, especially use them for these Gaia series and other CTO wires which do not have so much cover. So the guide wire covers, and do not confuse them with coating. Coating is more proximal. The covers are at the tip mostly. They provide smoother surface for hydrophilic coating, smooth tracking through a tortuous vessel, and not to be confused with hydrophilic coating, which is more proximal. So look at the tip. Polymer tips help you to slip through a tougher lesions. Now, let's come to the why do we have coils at the end of the guide wire? on the stainless steel body, you have these coils which helps you to maintain the constant overall guide wire diameter. If the tip becomes very thin, the core, the wire cannot become so sharp. It can perforate and go out or enter into the subintima. That's why you need these fine wires which maintain the constant diameter of the tip of the wire. Next, this allows for tip shape retention. When you have a coils compared to core bending, wire bending, these coil bending helps you to retain the shape better. And also, because they are coils, they gives you a better feedback. Otherwise the sharp object would have penetrated and not given you a good feedback. And also, because there is such dense coils, they give you good visibility to know where the distal wire is. Now coming to the tip styles, you need either for steering or tip stiffness. Either you need to rotate through a complex anatomy, or you need to penetrate through a cap. So core to tip, if you see, the precise tip control is important. When you have a precise tip like this, long core going till the tip, you have better steering. You turn, the proximal distal will turn, and also it gives you a good tip load, means it gives you enough strength to push against a hard substance distally and penetrate through it. So if you have the core which extends from the proximal part which is in your hand to the most distal part, that's called core to tip, is the core composition, then it gives you better steerability and it gives you better penetrating or tip load. When the shaping of the ribbon, the core ends much before the tip, then the shapeability becomes better and the tip becomes atraumatic because the pushability does not reach the tip, and this wire can be used for prolapsing. At those junction, when you want to do a knuckle technique or something, you can use for prolapsing the wire. So this is what, talking about all this construction helps you to understand torque control, trackability, steerability, flexibility, prolapse tendency, tactile feedback, crossing, and support. Now, what are the other terminologies? Working length. Usually the wire, you can see at the bottom of the picture, the last 3 centimeters to 30 centimeters is the workable. The 3 centimeter helps you to cross the lesions, and the remaining 27 centimeters helps you to take the balloon and the guide. Both segments are important. Tip flexibility, that means amount of flexibility at the distal 3 centimeter. This is very, very crucial. The distal 3 centimeters will give you what you call flexibility, whether it will bend, non-bend, and all that. Then the tip load, this is the amount of force in grams it takes to buckle the most distal 1 centimeter. The last 10 millimeter of wire tip to bend, how much force you need to put, that in terms of grams is called the tip load. You want the less load in a type A or type B lesions, but once you're into type C lesions, or you want to do a CTO, you want more tip load to cross them. Then there is something called,
Girish, how much time you will take, Girish?
Maybe then I'll conclude by showing on 5 cases, sir. 3 minutes?
Yeah, give them a practical tip towards which wires would be your first choice and why, and what are to be avoided, what are the issues related to that. Can you do that?
I'll do that, sir. I think I came to that. The guide wire selection may be influenced by the vessel takeoff, that is acute or obtuse, vessel anatomy, whether tortuous, or lesion location, whether ostial, proximal, or distal, or lesion morphology, means just plaque rich in cholesterol or calcified or fibrotic, and then the device strategy. You want to do microcatheter, or you want to take rotablation and other things. For a left main angioplasty or a very osteoproximal LAD, if it's a type A or B lesion, any wire can be used. Preferable to use common wires which have least traumatic tips and have got at least medium support to take your wires, the devices like stents and balloon. But if you're doing ostial left main or ostial RCA, better to use an extra support because the whiplashing would be much lesser. In the bifurcation, for the primary lesions, you can choose what you want, but the side branch, there's always a possibility of jailing. You can use both hydrophilic coated or non-hydrophilic, but avoid polymer coated, the wires, which may get entrapped on or get stuck. The risk of wire rupture during pullback is slightly more when you use polymer jacket. In a case like acute ST elevation MI, when you see there is soft plaque and atraumatic wire is your preferred choice, less tendency to stay subintimately, and support usually less crucial, but thrombectomy device can be bulky. In this case, you can see here, there's a proximal subtotal occlusion, maybe, and when it is subtotal or a total, it is better to have a wire whisper, which is configured like this. I will just show you an image of the wire. This wire is like this, just for your understanding. It's a polymer cover, goes up till the tip, and the core to tip is the metal, and it is a parabolic grind which gradually tapers down. Next, it's the same. If you have something like that, acute MI, you can use, in such situations, you can even use a regular wire like BMW, but always better to use a whisper so that you slip in much easily. But keep a watch on the distal tip. So this is how you can access without much effort, and you can do thrombectomy and then stent or whatever is to be done. Now, when you have a distal tortuosity, here this is a post-bypass patient, the lima had failed, and she came for unstable angina, and there's a very tight proximal and distal lesions. So we are worried about how to cross the proximal lesions, but we're also looking at how to cross this. If you pay attention to the mid to distal portion, there's almost 360-degree curve, and then the wire goes down. We took BMW wire initially, not focusing too much on the distal segment, and then tried a whisper, tried another hydrophilic wire like what do you call pilot 100. It did not cross. Then finally we had to go to a cyan blue wire. So you can see that knot like thing in the LED could be crossed with the help of this wire, purely because the way it is constructed. Simply because the way it is constructed. How is it constructed? There is a 50% which is coated with nitinol, 50% is bare, and it is very flexible and at the same time atraumatic. So it can take a 360-degree turn and go through that. You can see this. It's taking that 360-degree turn and straightening that segment and go. So when you have something like this, you need to select depending on the way the wire is constructed. That's why it's important to understand how these things are made and how to select your wires. Now you have here another case of acute unstable angina post-bypass where a graft failed to a PDA and came with acute inferior wall MI. This is how the lesion looks. Quite along the distal part of the circumflex is occluded. So initially we tried with a whisper wire, it did not go. We thought we should either take a Fielder XT or we should take a Pilot 100 or 200. But then eventually we decided upon Fielder XT. Why? It's again the stainless steel core which goes till the tip that gives you a beautiful transition less without any transition. So torqueability is excellent. And the distal one is hydrophilic coated, so it will slip through subtotal occluded, because post-CABG means very chronically occluded disease. This is not something thrombotic. So you need to track through a channel like you can see below. And it is again, there is a polymer on top of it. And inside, again, you have what we call the, the wires, coils. So it helps you to maintain the tip shape, because you make a very small at the end of about 3 or 4 millimeter, you make a 30-degree bend, you can access any of it with this help of this wire. And this is how we got into that place. After failing with 2 wires, we could cross with this. Why? Because it does not prolapse. The tip does not prolapse as much as other wires, and it gives you a very good support over a period of the distance, and it easily tracked until the distal. And it's important to take help of microcatheter if you're in a challenging situation. Now, if you're into certain calcified lesions, this man presented an acute enterovall MI. It is not a CTO lesion, it's an acute enterovall MI, and this is how the lesion is. Probably he had a very dense, severe coronary artery disease, calcified lesion, and a small thrombus occluded the remaining channel. So we tried initially with many wires, including Whisper and hydrophilic coated, even Pilot did not cross. Then we had to take non-hydrophilic, tough one, the ones with a higher tip load like Gaia 2. And you can see here, we had to take a microcatheter. My request to all young doctors, in whichever lab you're operating, please keep some, hardwares like a microcatheter, like a Guidezilla, like a thrombus aspiration, wherever you work. Keep a couple of them, and also on the shelf, keep a couple of complex wires like Gaia 3 or Pilot 200. If you're caught up in a situation where you cannot cross, you can try these. And then exchange these wires. Remember to exchange these wires. Never do angioplasty on these wires. Exchange them to a regular workhorse BMW or a extra support before you take other device like balloon and stent. And if you have a very tortuous vessel, again, this I just did yesterday. I had nightmare. Look, I addressed the left, both the vessels easily. Looking at this, it looks very innocuous, large lumen, but whatever I may try, the wires would not cross the mid segment. And it was so tortuous in RAO, and no wire. We tried Whisper, Xianbu, Pilot. Even I tried, the Fielder XT without a help of a microcatheter, hoping that it's such a big one, nothing would cross. I took 30 minutes to just cross such an open vessel. Then we realized later that there was a chunk of the calcium which was blocking that. So when I took the help of the microcatheter and then passed, it really took. So when you have a tortuosity, it's important to have thin tapered wires which are hydrophilic, which you take you through the lesions, and then you exchange them. Never leave them, don't operate on them. Exchange them with a workhorse wire before you come back to your intervention. Here again, you have a subtotal occlusion enterovall MI, but pretty tortuous. You can see right from the ostium, the lesion seems to be tortuous, or the calcium has pushed it to one corner. So again, we tried with regular Whisper wire, Sion Blue, Fielder XT, we could not cross. In a myocardial infarction situation, again, we had to resort to Gaia 2 to access. So do not hesitate. If you know how the wire is constructed and what to watch for, when it helps you, it also can harm you. So for the last touch on the CTO wires, you need a penetration force, you need a pushability of the wire, you need steerability, means you need to direct it to the area that you want. You don't want to go to the intimal side, away from the intima, and you want the tip to retain its memory till you penetrate it through the plaque. So you need a penetration force, pushability, steerability, and shaping memory. So when you look at the wires, either you have non-tapered or tapered, when you either have a hydrophilic or non-hydrophilic. Hydrophilic are good to access the proximal part of the cap, but not good to exit the lesion. Non-coated, non-hydrophilic, hydrophobic ones are very good to enter into, from the subintima, enter into the lesion or true lumen and stay within the lumen. And this is how to summarize. If you have a regular, straightforward controlling, you need to enter through a hydrophilic wire. then try and exit through a non-hydrophilic wire. In the third lesion, you can see there's a small tracking microchannel. You can use a sliding technique that either Fielder XT or FC can be of use. And sometimes there can be a concertina effect because of a hard shaft or what you call stiffer shaft. Once you change over to a softer vessel, you can see the graft so beautifully it opens up. In summary, your success depends on choice of your wire. So for that, you must understand, spend a while to read about the construction and each part of the wire and look at each strength and the risks that they bring upon when you once you take onto your hands. So for a straightforward anatomy, use a trustworthy workhorse like a BMW or a Whisper. But once you need more support, use an extra support wire alone or a buddy wire when stent or balloon don't track. And for more tortuous or calcified lesions, use hydrophilic polymer-coated wires like Whisper or what you have, Pilot 200 to cross the lesions with the least, risk of what do you call resistance, but it also can cause you a perforation. Remember that. Thank you, sir. And for subtotal occlusion and CTO, it's always better to use a wire like Fielder XT to begin with, and with the help of a microcatheter and upgrade it to stiffer tipped wires later. And when you're not sure where you're going and what is happening, it's always better to use a microcatheter inside which you can constantly keep changing your wires depending on how much your trackability, force, or penetration power you need. Thank you.
Thank you, Girish. I think he gave us all the description of the various types of wires, and of time we are unable to spend much time with him. But I just want to sum up his presentation. Which is the wire you would use as your workhorse wire, Deepak, Girish?
I think at this point, BMW is the workhorse for me, sir. Or
okay. Okay. I mean, my personal advice to all of you, we have seen that today there are at least 20, 30 different types of wires are available. You must learn for the youngsters who are coming up or just starting or in the early 100 cases or less, you should start with one wire which you are familiar, continue to use that, and then keep on graduating from that. Don't, because somebody said in a meeting, you can use this wire, that wire, you can use, now Girish said we can use a Gaia for any difficult lesions. Doesn't mean that you must go ahead and start using Gaia for all difficult lesions. You will land up in trouble. You upgrade yourself slowly. Don't be in a hurry to keep on upgrading, and try to understand and then go forward. Now we'll have to go back to Shiva, no? Shiva, are you?
Yeah,
Shiva?
Yeah, I'm here, sir. Yes, sir, I'm here. I have shared my slides through mail, and hopefully, if they can share me back. Am I audible, Deepak?
Yeah, yes, Shiva.
Yeah, Lijo, I requested Lijo to share my screen.
Yeah, Lijo
we can do that. Or Deepak, you can.
Shiva, we are running short of time. We are already half late.
Sir, by the time Shiva is sharing his screen, sir, what is your workhorse at this point of time? We know that you are a great fan of BMW wires. Now with the newer wires, the Versaturn and all, have you slowly switched over to something new, or what is your workhorse at this point of time?
I'm still BMW Universal as my the workhorse wire.
Yes, sir. Happy to hear
each other wire. Yeah.
Shiva?
Yeah, just...
Before Shiva comes up, I just wanted to... Now we have almost 230, 250 people listening. There is a little dilemma. We were supposed to have our India Live 2021 February. And I need all of you to give me a feedback. Would that be feasible? Whether we should attempt to run the meeting, or what do you want me to do? We are planning end of February 2021. Will it be possible, and what would be your response? Will you all come? Otherwise, we have to plan and postpone this year's meeting to next year. Something we have to do. Why don't you give me a feedback through Abbott colleagues, or you can write to me directly?
Sure, sir.
Sure, sir. Deepak, can I proceed?
Yeah.
I think, sorry for the inconvenience I caused. Now, I have dealt you the recurrent radial artery, arterial lusoria, and balloon assisted tracking, loops, and how to get away the loops. And regarding engagement, for the RCA, you can use JR or easy right radial, or Ikaki right, or Ambulance left. Next slide, please. For the left, of course, the choice is extra backup. And this is what we do. When we moved from the diagnostic to PCI, this was the invention which we learned from Dr. Matthew sir, that once you loop the guide, take the help of a wire, take the wire hard end, don't come out of the wire, out of the guide, and with the help of wire, you can get into the coronaries. This most of the time works with the extra backup. Of course, we can use easy right radial also. As I said earlier, you use a counterclockwise or clockwise accordingly where the initial position of the guide. And this technique almost always helps. Loop it, bend it, take a stiffer part of the hard wire, don't come out of the guide, and manipulate and get in. Next slide, please. And there are, as I was mentioning earlier, there are universal guide technique. There are one guide which we can use for both right and left. This is for the want of less exchanges to prevent less contrast, less radiation, fluoroscopy, less stroke risk. You get in with an RCA guide by MAC catheter, engage the RCA, then loop it, then pull it back, it engages into the left. Similarly, next. There's a universal left guide wherein you hook the left, and similarly, like a JR, you can hook to the right also with a single guide. Of course, we can do it with a regular extra backup guide also. This also I again picked up from Tejas, that, but yeah, there is a risk. Sometimes it deeply engages and decides. So you need to have that caution when you manipulate with a single guide for both. Next. Next, please. And regarding other areas like graft access for the Lima, SVG, we can make use of left radial. For Lima and Rima, you can use femoral or right radial in special situations. For the SVGs, right or left radial. Of course, earlier days, during your learning part of the curve, you can use left, and later on, it doesn't make a big difference. Once you are used to the radial access, you can play with right radial with usually how you approach femorally. Next. And regarding complications, there is a hematoma issue, particularly when the wire goes up front, when it goes into the, particularly in a primary PCI subset, when there is a lyse elsewhere, when there is a rescue PCI, when there is a loading dose on, there is a 2B3A for a bailout. Sometimes a small wire hitting, thermo wire hitting on somewhere on the lateral thoracic valve, you get a unknown sites on the neck, on the back of the chest, on the front pectoralis, all those areas you get a nasty hematoma. It is very anxiety, but unlike femoral, these are all access and non-access site bleedings doesn't cause great morbidity or mortality except for a cosmetic issue, usually settles down. And compartment syndrome, I never come across single case. Regarding AV fistula, I had one case. It was like a created fistula by a surgeon, CPS surgeon. I had sent the patient for a surgery, and for a pseudoaneurysm, if you recognize early, you can take the help of a radiologist with an ultrasound. You can constantly compress over the neck and get it off. Regarding nerve damage, it is your technique. Make sure the nerves are all running very parallel to these arteries, whether it's ulnar or radial. Make sure you don't hit to those areas. And catheter entrapment, this is one thing. When there is a severe spasm and catheter gets entrapped, there are situations people have even stripped a radial artery. There are situations where people have torqued and broken the catheter. So when there is an entrapment of the guide, what you can do is take time, leave it for some time, allow the spasm to settle, and give increased anesthesia by fentanyl more. Sometimes people have given even GA. You can give a nerve block. What generally I do is you can inflate the BP cuff over the forearm, over the arm in the above the cubital fossa, and increase it to more than 10 millimeters of the systolic BP. Once you do that, spontaneously the radial artery opens up and the catheter, whatever trapped, slips down. Next slide, please. And to summarize, sometimes when there is a failed radial, failed right, failed left, failed ulnar, there is a now there is a debate between whether to go for femoral or brachial. That was always going in my mind, but there is a slight advantage of brachial over femoral in those situations because the complications were slightly lesser. But in these kind of a bailout brachial situations, however, compared to radial, you don't enjoy the lack of acute limb ischemia because it is above the bifurcation, so the ulnar doesn't come for the help. So one should never go for the brachial by choice. You should keep it as risky as a femoral because here also there is an aneurysm, there is a huge hematoma, and it can cause ischemia because it is choice is right radial, left radial, ulnar. If there is thin built, still you can go for operators like Matthew sir. Definitely the choice immediately comes femoral. But if you still want to avoid femoral in obese people, in a primary PCI rescue, backdrop of so many anticoagulants, need a clean puncture of the brachial. Don't counter it. Make sure you don't get an acute limb ischemia by a clean puncture. Thank you, one and all. Sorry for the inconvenience.
Thank you, Shiva. Any important questions, Deepak?
Yes, sir. How to decide how much shape to be given to the wire? What should be the, how should be that particular point be decided, like whether it should be 0.5 millimeter tip or?
Which was the access wire for the radial?
Yeah. No, that was actually for the Dr. Girish talk.
Okay.
Girish talk. Okay.
For the coronary wires.
Okay.
I mean, ideally you should have a very short tip because that will have a much effective control on the tip of the wire. You must decide the tip length only by looking at the lesion and how to reach and where the location is. That is from your experience you will learn over a period of time. And Shiva, thank you so much for the talk.
Thank you. Thank you, sir. Yeah.
And go ahead, Deepak. You will talk on the guiding catheter.
Yes, sir. Thank you so much, sir. Good evening once again to each and everyone. It's my pleasure to be with you all. Shall take you through the choice of guide catheter, optimizing the guide catheter during angioplasty over the next 20 minutes or so. Now, we all know that guide catheter selection is the key to success in a coronary intervention. Now, when you decide on an angioplasty for the right coronary artery, see what exactly is the origin, the course of the right coronary artery is like. If it's a horizontal course, always you could go ahead with a Judkins catheter. Keep in mind that the support that you get while using a Judkins catheter is the least compared to most of the other guide catheters. Now, when you have a right coronary that goes inferiorly, the best choice would be the multipurpose catheter as seen in the second image. And when you have an upgoing right coronary artery, a Shepherd-Crook RCA, the catheter should probably be an Amplatz catheter, or you could go for a hockey stick guide catheter. Now, this is an example of an upgoing right coronary artery, a Shepherd-Crook RCA. You could see that there is a proximal CTO in the vessel with bridging collaterals. You could also see that the Judkins catheter is sitting just at the mouth of the vessel. You are almost sure that if you were to do an intervention with the Judkins catheter, you are unlikely to cross the lesion. Now, in this particular situation, you could see clearly that the Amplatz catheter, that's an AL1 catheter, it's sitting right at the ostium of the right coronary artery. We could achieve a good support with that with the help of a microcatheter and a concave screw. We were able to cross the lesion and we were able to achieve a good support. So, primarily, when you want to have a good support, one should probably think in terms of an Amplatz catheter. Now, this is another example of a distal CTO in a right coronary artery. You could see that the Amplatz AL1 catheter is used to engage the catheter. We cross with a heavyweight wire, and finally we were able to achieve a good result. Now you could see here that the amount of backup support that we get with this AL1 catheter is excellent. Now the challenge with this sort of Amplatz catheter would be you are likely to dissect unless you are careful. So one should always be careful. It's always a compromise. It's a trade-off. When you want to have a good backup support, you think about Amplatz catheter, and then probably in those situations, unless you're extremely careful, you're likely to dissect the coronary artery. Now, we always have a mental resistance while using an AL1 catheter for doing a right coronary intervention, because we always know that unless we are extremely careful, we are likely to dissect the ostium of the right coronary artery. So we have at this point of time, we commonly use this particular catheter known as the short Amplatz left catheter. It's available at this point of time in India. We call it as a 0.75 AL 0.75. This is a short tip guide catheter. It's not as traumatic as the AL1 catheter. It just sits at the ostium of the right coronary artery, and you get a good amount of backup support with this particular catheter. It's presently freely available. So when you want to have a complex intervention for the right coronary to be done, probably think in terms of this SAL catheter. It gives almost as good a support as the AL1 catheter, but it's less traumatic compared to the AL1 catheter to the right coronary artery. Now for the left coronary artery, it's always the extra backup guide catheter that would give you that would fetch you a good amount of backup support and take you through most of the complex coronary intervention. But there are only very few situations where we tend to think in terms of a Jenkins catheter for the left coronary system. When you have an ostial left main disease, using an EBU catheter would be more challenging. You might injure the ostium of the left main. So in those situations, probably one should think in terms of a Jenkins catheter. Moreover, when you have a twin origin of the left coronary artery, when you have a separate origin of the circumflex as well as NAD, probably you might have to switch over to a Jenkins catheter. Most of the other situation, an extra backup catheter would be the most ideal one. As Dr. Shiva has alluded, during a transradial intervention, always for the left coronary system, extra backup catheter would give you the best possible support. And for the right coronary intervention, a Jenkins catheter would give you a good support, but there are situations wherein you might need a extra backup support for the right coronary intervention. Those situations you could use this Hikari catheter, wherein you have a secondary curve for a good secondary curve for this catheter. It would hug on to the opposite wall of the aorta and fetch you good support. This is a tortuous proximal right coronary artery. The first image shows you that it's the Tiger catheter we've used for the angiographic evaluation. In the second top image, you could see that we've tried to engage with the Jenkins catheter. You could see that it's just sitting at the mouth. It would definitely not give you any proper support for this intervention. And the third image, you could see the Hikari catheter from the pterygium. You could see that it's seated properly in the coronary artery. It's getting support from the opposite wall of the aorta, which would give you a good backup support for the complex coronary intervention. Now, one should always know about the stiffness of the guide catheter. We have two EBU catheters, extra backup catheters from the Medtronic, the green one, and the blue one from the Cordis. Matthew Samuel sir would always prefer the Cordis catheter because he feels that in a very complex lesion, it's a very stiff catheter. When you continue to work on for half an hour, 1 hour, it doesn't become soft. But we mostly prefer using the EBU catheter from the Medtronic just because it's a less stiff catheter, less traumatic, and so we prefer using the Medtronic EBU catheter. And also one should keep in mind that the tip curve, the primary curve, is a little more extra for the Cordis catheter. If you're used to a 3.5 EBU catheter, if you want to switch over to a Cordis catheter, probably one should think in terms of a 3 catheter because the tip length is a little bit more for the Cordis catheter compared to the Medtronic EBU catheter. And when you think about the left system, when you want to go for a Amplatz catheter, you should know that different companies have different shapes and different lengths for an Amplatz catheter also. Now coming to the anomalous right coronary artery, how to engage the anomalous right coronary artery, you have different options. In the first image, you could see that it's an Amplatz catheter. That's an AL1 catheter which is used to engage the right coronary artery. This right coronary artery is coming from the left coronary sinus. It has been engaged with the help of an Amplatz catheter. In the second image, you could see that we did the intervention from the radial approach, and initially it was easy to hook with a tiger catheter. So we decided that we would try doing hooking with a Ikari catheter, which has got a curve very similar to the Jetkins, similar to the tiger catheter. So that's the Ikari catheter. With the help of this catheter, we were able to complete the intervention for the anomalous right coronary artery, which is arising from the left system. This is again an anomalous coronary, right coronary from the left side. We have engaged with the Ikari catheter, and you could see in the lateral view, right lateral view, how the catheter sits well inside the anomalous right coronary artery for the intervention. Now, one could also go for a left Jetkins catheter and an Amplatz AL2 catheter when you find it challenging to engage the vessel. This is an anomalous right coronary from the left system. In the second image, you could see that the origin of the vessel is almost a slit-like thing. In the second image, you can very clearly identify that. In this sort of slit-like origin of the anomalous right coronary artery, engaging and having the intervention is challenging. You might encounter pressure dampening. So get the wire deep inside the vessel and try to slowly disengage the guide catheter so that you might not injure the vessel. Now, one could also use an extra backup guide catheter for engaging the anomalous right coronary artery, which arises from the left system. So a Jetkins catheter, a left Jetkins catheter would be useful, an extra backup catheter would be useful, and an Ikari catheter as well as an Amplatz catheter would be useful in situations wherein you have an anomalous origin of the right coronary artery. Now, regarding grafts, you have the right-sided grafts as well as the left-sided grafts. Right-sided grafts always Jetkin catheters. The right Jetkin catheters are very easy to engage, but then it's a trade-off. You do not get any backup support from these catheters, the regular Jetkins catheters. So we've learned from Matthew Samuel's stalwarts like Matthew Samuel sir, like in situation when you have a graft intervention, a catheter that provides you with a good support, like a multi-purpose catheter or an Amplatz catheter, would be the ideal catheter for the right system, and an AL catheter would be ideal for the left system. This is a right coronary, a vein graft to the right coronary artery, which is totally occluded. You could see in the first image that it's a Jetkins catheter sitting at the mouth. It's not well coaxially aligned to the vessel. You could see in the first image. In the second image, you could see that it's a multi-purpose catheter which is sitting well inside the vessel, and we could easily complete the intervention with the help of this multi-purpose catheter. So just to highlight the fact that it's easy for us to engage with the Jetkins catheter, but when you want to have a distal protection device, when you have a good backup support in those situations, a multi-purpose catheter would be the ideal one for the graft arising to the right coronary artery. For the graft arising to the left system, and Amplatz catheter would be a good option. Here you could see that this ostial stenosis of the graft to the left anterior descending artery. That's the AL1 catheter, which is sitting snugly at the ostium. We could get proper support. It was a difficult intervention. It was a tight stenosis there. We had to use a cutting balloon and finally achieve a good flow in the left anterior descending artery. Now, you could also use an extra backup guide catheter for engaging the vein graft. Here, you could see that there's a vein graft that's diseased to the OM system. You could see that it's an EBU3 curve which is being used to engage the vein graft. And following that, you could see in the second image that it gives you so much of backup support. It was a little bit difficult for us to track the stent inside. You could see that we could achieve a good backup support with the EBU catheter, and we could complete the intervention for the graft to the circumflex artery. Now, coming to Lima, most of us, we tend to do Lima angiography with the help of a Jetkins catheter. It's always good to do the Lima angiography for a better optimal visualization with the help of a Lima diagnostic catheter itself. In 90% of situations, you would be able to easily engage the Lima vessel with the Lima catheter. You just have to go distal to the Lima, pull it back slowly, do counterclockwise torque, and you'll be able to engage the vessel in most of the situation. This was a Lima intervention wherein the Lima was arising from the roof of the subclavian artery. We were not able to engage with a Lima catheter. So in this particular situation, we used a Jetkins catheter. You could see that with the Jetkins catheter near the mouth of the vessel, we try to float a fielder FC wire into that. You could also see that there is a long lesion in the left anterior descending artery beyond the anastomotic site of the Lima. And following that, we were able to track a 48 millimeter expedition stent into that. That's the 48 millimeter stent going into that, and it's being deployed. The point that I wanted to highlight is not this particular thing. Many times when we are bothered about the distal left-handed descending artery, we never look at the ostium of the lemma. We are likely to uh, produce dissection of the lemma ostium. So in order to avoid dissection of the lemma ostium, you could also always have a second wire floating inside the distal subclavian artery. This is a technique that we have learned from Matthew Samuel, sir. One wire you used to get into the lemma and wire the left-handed descending artery. The second one, for as seen in this image, it's well inside the distal subclavian artery, so that it prevents the lemma guide or the Jenkins guide from sucking into the lemma, because you are concentrating low down in the vessel. When you pull out the non-compliant balloon, or when you pull out the balloons after the stent deployment, you are likely to push the guide catheter into the lemma, and you are likely to dissect it. So in order to avoid that, always try to have a wire in the distal subclavian vessel, and once you complete the intervention, you can take out the wire and hook the vessel properly, and that's the final shoot. You could see that the flow in the vessel is good, because I personally have dissected 2 lemma for my patients. So nowadays I never avoid doing this particular technique. I always have this wire positioned in the distal subclavian so that the guide catheter does not get sucked into the left internal mammary artery. Now, this was a patient who had a very soft type A lesion in the right coronary artery. We did the procedure, we did the diagnostic angiogram through the right radial approach. However, when we tried to get the guide catheter, it wouldn't track through, and so we did an angiogram. You could see that, as Dr. Shiva has mentioned, this is basically an accessory radial artery, and this accessory radial artery has produced a loop over there. You could see that there is a loop over there, and this is a small accessory radial artery through which we have done the angiogram, and now the guide catheter wouldn't go through that. You could see that at this particular point we have produced a dissection also in the accessory radial artery. Now this is a huge loop. We could not imagine to straighten this loop and go through the main vessel. So we tried going through the accessory radial artery itself. We tried using a balloon assisted technique. You could see that here you could see that the vessel is dissected. In spite of that, we were able to manage through that small vessel with the help of balloon assisted technique, and the stenting was done. And following that, this particular image shows you how exactly we pulled it out. You could see that it's an anomalous accessory radial artery, and following that, as we pulled it out, you could see that whatever dissection was there initially, it is totally sealed off. So in a radial artery, when you encounter a dissection, try to complete the procedure through the radial artery without as such creating more of trouble to the vessel. And by the end of the intervention, most of the time, the radial artery dissection would have settled down. So just to highlight the fact that you could use a 5 French guide catheter through this accessory radial arteries, so that you can reach the coronary and do the intervention through the accessory radial artery. Now, another 10 minutes, I shall take you through how exactly one could optimize the guide catheter support for difficult intervention. This is a left main calcified stenosis, the angiography being done through the femoral approach. And now the most important point one should keep in mind is long sheath. When you have a 65 centimeter long sheath, when you go for a bigger French guide catheter, a 7 French guide catheter would definitely give you a better backup support than a 6 French guide catheter. So here we have used a long sheath, that's a 65 centimeters sheath going till the descending aorta, and this long 7 French guide catheter. Following that, we were able to complete the intervention without any difficulty. Just to highlight the fact that a bigger sheath and a longer sheath would fetch you good backup support for most of your intervention. That's the final result for rotablation and stent implantation. Now, the second way of optimizing the guide catheter would be to use an aggressive guide catheter. This is a very tortuous right coronary artery. It's a Shepherd group right coronary artery. We opted for an Amplatz catheter. That's an AL1 catheter. You could see that it's a Fielder FC wire that's going through the tortuous vessel in the second image. And following that, we tried to do balloon dilatation, and we tried to track the stent into the vessel. We were not able to track a long stent into the vessel. Now, finally, we used a buddy wire. We used 2 wires, and finally, we were able to get a 38 millimeter stent into the vessel with a good backup support, a aggressive backup support with the AL1 catheter, and we deployed the stent. However, once we deployed the stent, we found out that distally there was a dissection. So then the problem that problem again was to get a next stent distally through the 38 millimeter stent. We tried to negotiate a shorter stent through the first stent. It was not going through. Fortunately, with the help of a buddy wire support, buddy wire, we were able to track the stent. The stent could slide in through the first stent distally, and we were able to deploy the stent. And you could see here that the amount of tortuosity in the right coronary artery, it's a shepherd crook artery. We were able to manage this particular angioplasty just because we used an aggressive guide catheter with a good backup support. So when you want to have when you have a shepherd crook right coronary artery, you could always go for a good guide catheter support. You could also offer an EBU guide catheter. In this shepherd crook right coronary artery, there was a distal stenosis in the PLV branch, so we used a 3-curve EBU catheter. So you could use an extra backup catheter for the right coronary system also. However, make sure that it's a 3.5 curve. It's a short curve. A 3 curve has been used to engage the right coronary artery, and following that, we were able to easily complete the intervention. In the first image here, you could see that the EBU 3 catheter has been engaged. The second image, you could see that the stent is being deployed. Finally, one should always make sure that before you disengage the guide catheter, make sure that the wire is never out, because in the last shoot, you might produce a dissection of the vessel. So keep the coronary wire, 014 wire, halfway in the right coronary artery when you do the last shoot, and following that, disengage the guide catheter as well as the coronary wire to make sure that you are not in a bad position in case you produce a dissection of the vessel. Now, the third technique of optimizing the guide catheter support would be to amplatz the guide catheter. We were working with a Jenkins catheter with no backup support at all. A distal occlusion of PLV branch was occluded. Proximally, there was some amount of calcium. We were not even able to get the stent through the proximal vessel because of the calcium in the proximal vessel. So we tried to amplatz the catheter. In the first image, you could see that we have done a clockwise rotation and pushed the guide catheter with a balloon that is being inflated there. So with the help of this amplatzing, we were able to get a better backup support. And in the second image, you could see that through that heavily calcified proximal right coronary artery, we were able to track the stent distally, and finally we were able to achieve a good result following a stent deployment in the proximal vessel also. So this sort of amplatzing the Jenkins guide catheter by clockwise rotating, torquing it and pushing it in with a balloon inflated inside the vessel would get us a better backup support. Now, deep throating the guide catheter also would fetch you a better backup support. This was a distal stenosis. This patient also had a stent implanted at the right proximal ostium of the right coronary artery. So we were not able to get proper guide catheter aligned at the ostium of the right coronary artery. The right and the left radial artery also was tortuous, so we had to go through the femoral approach. So what happened was we engaged with a diagnostic catheter. We wired the lesion with a 300 centimeter 014 wire, and then disengaged the diagnostic catheter, removed the diagnostic catheter, and over this wire we tracked a 4 French catheter, the Kiwami catheter. Presently, I believe it's not available here in India. That's a 4 French catheter which is used to engage the right coronary artery over the 014 wire. And then following that, we were able to deeply engage this particular Kiwami catheter deep inside the right coronary artery, and then through this 4 French catheter, we were able to get a stent distally deployed, could achieve good results. So amplatzing the left guide catheter, the Jenkins catheter, and deep throating the guide catheter would always fetch you good backup support. This is a proximal right coronary occlusion. We were able to cross with a fielder wire. However, the aspiration catheter would not cross through, and the guide catheter was going out of the vessel. So in this particular situation also, we were able to get the guide catheter deep inside the vessel. Following that, we were able to do a proper aspiration of the catheter, proper stent deployment, and then we were able to achieve a good result. Now, coming to the buried wire technique to achieve a good backup support, let's say you have a very long lesion inside your coronary artery. This is a long lesion in the left anterior descending artery. You could wire with 2 wires, and if in case your stent is not tracking well into the lesion, what you could do is you could deploy the first stent proximally. When you deploy the first stent proximally, make sure that the second wire, which is not a hydrophilic, it's not a coated wire, it is buried underneath the stent, which has been deployed proximally. Now you would get a good anchoring of the guide catheter, and then you could get a good anchoring of the guide catheter, and then you will be able to track the second stent distally into the vessel. So this is just the buried wire technique, wherein you could have a better backup support and you could get the intervention done. Now, this is a right coronary artery intervention, a distal right coronary artery in an 85-year-old gentleman, where we had used this buried wire technique. What happened here was we tried multiple balloon dilatation of the distal vessel. We tried using a buddy wire technique. In spite of that, we were not able to track the stent deep inside the vessel. So at that point of time, you could also see that proximally there is some disease. So we stented the proximal right coronary artery with a stent. However, at this point of time, we kept a buried wire there. That's a run-through wire, which is not a hydrophilic wire. So that was buried under the first stent. So that would anchor my guide catheter. And then with the second one, with the help of the second, with the anchor wire technique, we were able to get the stent distally into the vessel. The guide, you could see that as I am pushing the guide stent inside the vessel, the guide is not backing out, it's sitting there properly. So with this buried wire technique, we were able to complete the intervention in this particular patient. However, one should make sure that before you deploy the second stent distally, you need to remove the buried wire so that you might not bury it under two stents. So that's one important point. You should keep in mind that when you deploy the second stent distally, you always have to remove the buried wire before deploying it. And one should also keep in mind that it should not be a coated wire, so that pulling it out might be dangerous in those particular situations. Now, the anchor balloon technique also would give you a better optimization of the guide catheter support. Here, this is a CTO of the proximal circumflex artery. We were trying to wire it with the help of a Conquest Pro wire. That was a 7 French guide catheter, Conquest Pro wire, and a microcatheter support. In spite of that, we were not able to penetrate the proximal cap. So in that particular situation, we wired the OM branch, dilated the balloon over there, and with the help of this anchor balloon, we were able to cross into the distal vessel, and finally we were able to achieve a good result. Just to highlight the fact that when you have an anchor balloon support, you would definitely get a better guide catheter support for your coronary, a complex coronary intervention. This was a heavily calcified right coronary artery. You could see that it's got an eccentric calcification, eccentric plaque with calcification. We used a 1.25 bar just because we were scared that we might perforate the vessel if we were to use a 1.5 bar. So after burying, we were not able to track the stent into the vessel. You could see that as we were trying to get the stent across, the stent was getting stuck proximally inside the vessel. So we used a anchor balloon technique. A wire has been positioned inside the RV branch. A balloon has been inflated there. With the help of the anchor wire technique, anchor balloon technique, we were able to get the stent distally across, and we were able to deploy it. The usefulness of guideliner has been highlighted by Matthew Samuel, sir. This is an anomalous right coronary artery. We were able to do the angiogram with a Tiger catheter through the radial approach. Then we used a Jenkins catheter to engage the anomalous right coronary artery. Now you could see that it's just at the mouth of the right coronary artery. You're sure that it's not going to provide you any backup support. In the third image, you could see that in spite of using a buddy wire support, we were not able to track the stent into the vessel. So at that point of time, we used a guide cilla. You could see that a balloon has been anchored inside the coronary, and over that we were able to get the guide cilla inside the vessel, and then following that you could see that the stent could easily be tracked into the vessel. So in difficult lesions, definitely the guide cilla would fetches good backup support, and that's the final result. The image has been taken with the guide cilla there, and finally we were able to achieve a good result. Now this guide cilla, it's an expensive device. You could also go for a mother and child technique. It's a cumbersome technique, but then you could use a heart rail 5 French catheter through the 6 French guide catheter and get the procedures done. Only challenge would be it's a cumbersome procedure. You need to remove the Y connector, you need to attach the hemostatic valve, and through that you could go distally, and it could be used as it's very, very similar to the guide cilla. Now this is a distal right coronary artery occlusion. The stent was not tracking through, so we used an poor man's guidezilla. That's the mother and child technique. A balloon has been dilated distally, and over the balloon we are tracking the 5 French heart rail catheter distally, and through that position catheter distally positioned inside the vessel, we were able to track the stent distally, and finally we were able to achieve good result. So these are few techniques that would help us to achieve better backup support with our guide catheters. Also, you could have trouble with the child catheters. Also, you could have trouble with the guidezillas. Also, this is just an example, and I'll stop with that just to highlight the fact that you could have dissection unless you're very careful with the guidezilla or the child catheters. You could also have air embolism with these catheters. This is a circumflex. This is an acute inferior wall in my patient who had a circumflex stenosis. It's a very short, discrete stenosis, but somehow we were not able to track the stent into the circumflex artery. So, even with the help of body wire, the stent wouldn't go in. So we used a guidezilla. You could see that the guidezilla is being positioned, and now in the second image you could see that there is some amount of staining in the roof of the left main. So we found out that there was dissection of the left main. You could see here in the first image as well as the second image, we have dissected the left main. So what we did first was to stent the left main into LAD. We wired the LAD, stented the left main into LAD, and then we crossed through the stent struts into the circumflex artery, opened it up, and finally we were able to get the stent inside, and we were able to deploy it distally, and that was the final result. Just to highlight the fact that one should be very careful while using these sort of guide extension catheters, so that you might not encounter air embolism with this guide extension catheters, as well as dissections could be avoided while using these sort of catheters. So these are several techniques to increase the guide catheter support. One could use a long sheath. You could use a large size guide catheter for a better support. You could do a deep intubation of the guide. You could Amplats it. You could use multiple body wires. You could use a buried wire technique. You could use various anchoring techniques. You could also use the guidezilla as well as the mother and child technique for better backup support. So one should keep in mind that doing coronary intervention, always avoid accepting satisfactory backup support. Always try to prefer optimal backup support in most of your coronary interventions. Thank you so much.
Thank you, Deepak. It was a very, very exhaustive guiding catheter discussion you had. Still, there are about 175 people attending the webinar. Just to warn the people, I want all of you to forget the second part of Deepak's presentation, the high-risk cases and difficult cases. Unless you are doing at least 100 cases a year, don't try any of those techniques, because you need a lot of dexterity, you need a lot of experience before you can start embarking on the second part of Deepak's presentation and the lecture. Because manipulating all those devices and using ambulancing the guiding catheters and all are technically very challenging, and the risk of the procedure is also very high. The last part, using guideliner or guidezilla can solve most of the problems which arises out of difficulties what we have without having optimal support from the guiding catheter. That would be my first choice than using all those techniques which Deepak described for the beginners. Once you are experienced and you are doing 100 cases per year, then you can go on to what Deepak showed you. Then another few comments is about the Lima catheter, Lima dissection at DOS. As Deepak said, using the two-wire technique is extremely useful. You should always try. The main reason is Lima invariably would be grafted to the LAD. And when you are working on the distal anastomosis or the distal part of the LAD, the ostium of the Lima is not visible to you at all. The maximum amount of dissection happens when you start moving the balloon and stent at the site of where you need to be working, that is at the anastomosis or distal to the anastomosis. Those are the areas generally we'll have trouble in LAD Lima anastomosis. When we are working there, your visibility at the ostium of the Lima is totally away from your vision. So what happens guiding catheter, you will never realize. Only at the end of the procedure, you will realize. So using a second wire in the subclavian artery will prevent that anxiety, and you can be rest assured that problem is all probability avoided. Or as I mentioned about the usage of Guidezilla or guideliner, that also can be done even in the left main ostium. Lima ostium. You can advance a Guidezilla there, and that would prevent the movement of the guiding catheter into the ostium, and that can avoid this problem. Then coming to the usage of ambulance for the right coronary artery, ambulance for the Lima graft, because he mentioned about using multipurpose as the first choice. The short EBU, that is 0.75 EBU, also can be used. You can try very often. That is very helpful for the venous grafts engagement and interventions.
Yes, sir.
That's all my comments on that. Any other questions have come up? Deepak, just see.
Sir, Natarajan sir is also with us. Sir, we are able to see you now, sir. Sir, your comments, please, sir.
I just wanted Dr.
Hey,
I just wanted Matthew to see me actually.
At last I saw you.
It was a pleasure listening to you, sir, and your valuable comments, and all the lectures were extraordinarily good. Deepak, somebody asked you, I'll just read out a few questions for you to answer in case you didn't see the chat box. The buried wire technique was an extraordinarily useful information that you gave to all of us. Somebody asked a question. I actually was typing when you were talking about this buried wire. After taking the second stent, you should remove the buried wire, because removing the buried wire with 2 stents deployed is going to be very difficult.
True, sir. True, sir.
Somebody did ask the question, how will you remove the buried wire through a stented first stent? That's what somebody asked you. Any technique?
Yes, sir. One needs to disengage the guide catheter before. Keep the first wire maximally distally, the stent maximally distally, disengage the guide catheter, and then pull the buried wire out. Be careful so that it doesn't go deep inside and dissect the ostium.
Maybe you can ask your assistant to have a hand on the guiding catheter a little bit more in the aorta when you do that.
True, sir. Right? True, sir.
That's right.
And Girish, I wanted to ask a question. When we do a LAD diagonal, let us say you're stenting the LAD and having a wire in the diagonal to protect it. There are a lot of people who say that a hydrophilic wire is dangerous to leave in the side branch, because when you remove it after stenting the main vessel, it can be a problem. They say hydrophilic wire. What is your, Dr. Matthew, sir, what is your comment on that? What wire would you use to jail a diagonal when you stent the LAD?
Natarajan, this issue of jailing a wire with a hydrophilic wire, we talked about it in the early days, because those days the hydrophilic wire of quality what we get was not available. It was a coated wire which used to shave off when you pull the wire underneath the stent. The present generation, the hydrophilic wires or hydrophobic wires, it doesn't happen at all. So we can be absolutely certain about it. I don't know if any of you are using a wire called the All-Star wire, which is a very good support wire.
I have seen you use it in the year 1998 and I worked with you.
Sir.
His favorite wire used to be the All-Star. He was a star and he used to use the All-Star wire.
No, All-Star wire is a very good support wire, but only defect with that, if that wire is underneath a stent, you are stuck, because that has got a transitional bulge which will get caught under the stent.
Yes, sir. Natarajan, sir, there is some data that says that even a coated wire or a hydrophilic wire can be caged or can be kept as a kept in the side branch while stending the main vessel from the European data. But as Matthew Samuel sir told, most of us, we never try doing that. We use the workhorse.
Today we use it. Today we
Just the
use
workhorse wire.
I also do that. And one thing I've seen, invariably the guide telescopes badly when you
True, sir.
remove a jailed wire, and one has to pay very good attention on the guide catheter when you remove a jailed wire from a side branch. I'm sure Dr. Girish will agree with me when I say that.
Absolutely.
I've had accidents, the left main dissecting, etc., etc.
Yes.
Girish, I can't see him.
He's still with his PPE without the headgear.
No, I think perfectly said. Today, I think both hydrophilic and hydrophobic, both wires are constructed so well. I think most of us do not have issues pulling back them behind the stent struts. Even when they are between the two stent struts, they fairly come back well.
Matthew, sir, you remember you showed a case in San Francisco TCT some 10 years back when I was also lucky to be in the crowd, where you showed one of the most tortuous RCAs in the world possible. You remember that case, sir? One extraordinarily tortuous RCA with some 100 bends within the RCA, and you were showing step by step in that case. I think it was SFO TCT some 15 years back or something. You remember that case?
I don't remember. What was it, Present?
You were showing wiring an RCA which had some multiple fold-like bends, some almost like 50 bends in the mid RCA, and you took some wire and you crossed. The whole crowd was actually standing and giving you a standing ovation. What wire was that? I forget.
I mean, if it is 15 years, 10, 15 years back, none of these new generation wires were not available. All probability it would have been a combination of the microcapitals also were not available those days. So it could be a combination of an OTW wire, a balloon, and a whisper wire, and then changing over to the other wires in the over the wire.
You mean with an exchange length wire?
10% it must be that.
An exchange length wire. You had docking system at that time?
Yes, we had docking system at that time.
So
it must be because the newer generation hydraulic wires are not available those days.
So Dr. Natarajan, it was not the wire, it was the hand behind the wire.
That's correct.
That's that.
Right.
Thank you, Girish. It's too much.
Absolutely, a deserving compliment that you gave. And one point with Dr. Vijay Kumar said is very valuable is never pull a thermo wire through a beveled puncture needle. You should never ever do the mistake. Let us say you punctured, the thermo wire went inside, but you're not able to advance it. You should never remove the thermo wire. It's better to remove the wire and the needle together. Invariably, it will shave off the coating of a thermo wire. Vijay Kumar did mention during his talk. I just
That's right. Absolutely right.
Yes, sir.
Today, sir, coming to the guide wires, because of the choice that we have and the availability of microcatheters, anchoring techniques, and very non-traumatic guides, it's become much easier to access most of the lesions, unlike your times.
Yeah, today there is a lot of choice, but that is dangerous too, because we don't know what to use. Because there are too many things available. It's like a car today. When we had an ambassador and a Fiat, we knew only Fiat would be better. So today it's very difficult to choose a car.
Right.
Because each one have got its own features and advantages and disadvantages too. So learning to understand the wire is extremely important. So rather than trying to, because somebody used it, you saw it on TCT or PCR, somebody using a wire, doesn't mean that you can come and reproduce that. You have to learn to understand the wire and the construction, as you rightly said.
And your advice, sir, because most of the cardiologists who come in a post-graduation, they have some understanding of most, except for the choice of wires. So would you be telling them, this is the first line, this is the second line, this is the third line, maybe two for them? Would you give a message?
You see, we all grew up when we had limitations. We had companies working. One was ACS and the other was BARD. So there were limitations for the type of wires available. The ACS is the company which then moved on to Guide and then today's Abbott. So the BMW wire or similar wires were available even those days. So this is a wire which we knew for 30 years and it performed well. And all the modifications have been extremely carefully done and still it is performing. So I would still insist, prefer people to understand the BMW wire, understand the capabilities of that wire. 90% of the cases you will get away with it. And it has got a balance, it is properly named BMW, balanced middleweight wire. It is balanced for everybody. So that would be my first choice wire, and I would advise anybody to use that. If that is not feasible, then move on to the next wire. The Sion series is an excellent group of wires. The new wires which has come from Abbott, I can remember the name. Versatile. They are also a good set of wires. So we have choices of wires. You have to upgrade yourself, keep using it, keep on understanding the features and then upgrade it. That would be the best advice. And as Girish rightly said, hydrophilic wire, just don't leave it inside the vessel. Use it when it is needed and take it out when the need is over. I have had plenty of perforations using the first generation hydrophilic wires. Today's wires are safer, but still it is not as safe as the other wires. So wires, the Gaia or Conquest, all those wires, don't leave it inside the country when you are working on the other vessels or side branches or otherwise.
Dr. Girish, a lot of people in the chat box asked you the question in a very bad angled takeoff of a side branch, let's say diagonal. What is your trick? Which wire? How to get into the side branch? Because all the time the second wire keeps going into the main vessel. You're just not able to protect the diagonal, which deserves to be protected. A lot of people asked in the chat box.
I think that's good. You need two characteristics of the wire to be important at that point. One is the wire tip need to retain its shape all the time. You're going into the main vessel, coming back and trying to access the side branch. You may access, but when you push, it prolapses and go to the main branch. That's one. Second, you also need to have the torqueability, because it's not always that you are able to touch the ostium, because if it is pinched following your pre-dilation of the main vessel, again accessing is a slightly challenge. So I need three characteristics. The central core need to go till the tip. Second, I need a good shape retention. Third, I need a good torqueability. So for this, I think my first choice will be a Xion blue at this point of time, because it retains its shape for more than an hour when you're operating. Second, I can really curve in such a manner, like a guide you use for opposite end of the aorta and then go to the ostium. I make the curve in such a manner that the primary curve hits the opposite part of the LAD, and the tip needs to look into that. You shape it in a manner like that. Thirdly, I think you may just prolapse down into the LAD and then come back and then torque anti-clock and then enter rather than clocking it. These things have worked for me. If it does not, I think whisper is also not a bad idea. But then if you're in a horrible situation, even Pilot 200 is a floppy covered. If you bend the angulation correctly, you'll be able to access most of these side branches.
You answered most of the points extremely well. A lot of times the wire actually prolapses on the way back from the LAD rather than going in. Absolutely, very, very well said. And as you correctly said, the bigger the curve that you make, you may enter. Thereafter, you may have problems. That is when I remember Dr. Matthew's advice. Allow the wire to find its way. Don't try to push beyond a point. It has entered the diagonal. Facilitate the wire from going rather than being heroic in pushing is what he used to tell way back 22 years back when I worked with him. Allow the wire to find its way. That's what he used to tell. When you make awkward shapes to get into the vessel, you have to be very patient to let it find the way to the distal vessel. I hope sir will agree with me.
Absolutely. Still, it goes good. You have to guide the wire, and you have to have the patience to wait the wire to behave. The wire, as soon as you give the torque, it reflect at the tip. You should slowly give the rotation and allow the tip to take the axis into the side branches. Sometimes the secondary curve also can help. Primary curve, rather than making the primary curve bigger, retain a small primary curve and give a supportive secondary curve would be a better technique to access the side branch. I did see Shiva in between. Shiva, you can also comment. It is not your subject of the talk, but
Yeah.
you are experienced enough to comment.
I agree with you. The statement, the issue with the hydrophilic versus non-hydrophilic settle. They have done a microscopic study and proved that hydrophilic wires of present standard have not peeled off. And whatever K.U. Narajan said, that once you make a curve for the entry, that it becomes a disadvantage to further progress. Now, as Dr. Matthew said, allow with the wire, it will automatically. When you put a side branch wire, you need not go all the way down. Just keep it just across, because still the rodeo part, because you cross more distal, then you gyrate and you may peel off. So just pass across and keep it as minimum as possible. And now you have a better choice of wires, but there is a warning given by Dr. Matthew that Gaia 2 is a good wire, but definitely not a first choice. You need to have a learning curve with the Gaia Pilot 200 again. The current pilot standard, suddenly there is quality is dipped down, so we need to be little so each time there is the change is happening with the wires which we have accustomed. Suddenly there is a change in profile also. You need to keep on testing their profile, your friendliness with it. Suddenly the wire which you are accustomed, suddenly there may be some change in their design, or that you need to have keep on, you need to have the touch sensitivity. That is how I think everybody should have. The Cyan suggested by Girish is also a good choice, and Whisper for tortuous vessels, again a good choice. I think now we have plenty of choice, but like Dr. Matthew said, one should know which wire works for him and keep moving.
Just
Before you close, or before another comment, I saw suddenly a remark from one Dr. Nikhil. This is the best webinar he has attended in last few months. Deepak, thanks to you.
Congratulations.
I think this is a great credit to Deepak, the way he kept the topics and involved Dr. Matthew also.
Sir, reminding the next session also.
Yeah.
Next Thursday. Natarajan sir is always there.
Let's tell them, everybody, to limit themselves to the slides to time, the presentation, because we were exceeded by 1 hour today. We should stick to time and then allow enough time for discussion. Otherwise, there's no further meeting or webinar. This webinar was excellent, but it would have been better. It would have been in time.
Sir, but still 105 are here with us.
Absolutely, yeah. That's good.
Yes, sir.
But before you close, give me, now Natarajan is there, Shiva is there, Girish is also there, you are there. What is your take on, should we plan? I mean, a lot of negative reply I have received from all the international faculty for India Live 2021 for February. Should we try, hoping the vaccine will be ready by then? What do you all think?
It's very unlikely that you may have visiting faculty from abroad. By February, the pandemic is unlikely to settle to such an extent that you will have your usual quota of international faculty. You will have to do away without them. Maybe it's worthwhile postponing by a few months. Don't take a decision so early of postponing it to 2022. You can always wait for a few months and see how things evolve. They have not even taken a decision regarding the National CSA conference, which is due in the first week of December. So you have 2 extra months of cushion available. So you can always wait a little bit before we make a decision, is what I feel.
Yes, sir.
Yes, sir. I do feel vaccine is a remote possibility in February. So if you take a buying time of another extra 3 months, maybe second or third quarter of third quarter or fourth quarter of 22. Fourth quarter will be very late. Maybe in the middle of 2021, maybe an ideal choice, sir.
Yes, sir. I do feel so. The best interventional cardiology sessions in India, probably we shouldn't cancel it straight away. Wait for a while and then decide on that.
Okay. Okay.
Sir.
Shall we wind up today?
So you
Yes,
didn't
sir.
tell. So you didn't tell. One last point you can actually mention to the younger people about concertina with wires in a tortuous vessel. When you have concertina, you always used to teach that you remove the soft part of the wire little more back, withdraw the soft part of the wire, and if it is concertina, it disappears. Otherwise, people unnecessarily end up stenting a vessel when it is actually not needed. I remember you very often that thing.
Absolutely, Rajan. Absolutely. And I hope all of you understood what Natarajan was trying to explain. Go back and try to relieve the concertina and not take it out fully, but to keep the tip of the wire in the beyond the lesion and then try to see how the wire behaves, or the vessel behaves.
Correct, sir.
Okay, thank you so much, and it was a wonderful session, and we'll all meet on 30th, and let us continue the session.
Thank you so much, sir.
Thank you, sir.
Thank you.
Thank you very
Thank
much.
you.
Thank you so much.
It was great.
Thanks, Deepak. Thanks, KU.
Thank you. Thank you.
Thanks,
Matthew,
Shiva and Girish,
Thank you, sir.
Thank you, sir.
and Deepak and Natarajan, of course. Okay, bye.
Bye, sir. Good night, sir. Good night.
Good night.